Well, good morning, everybody. And thank you, Becky, for getting us started. And also thanks to you and the Garvey Institute staff for preparing a really great meeting today. This is the first time we're all getting together in person. Some of us are a little rusty at this, but it's so great to see you all. And welcome also everybody who is joining us by Zoom. So I'm going to do just a little bit of an overview of what we're going to try to do today. We're going to start with some introductions and a welcome from our president, and that'll be followed by a really brief overview that I'll do between now and 9 o'clock of the work of the Institute. And then starting around 9 o'clock, we're going to have a series of brief presentations on three things. Some of the really amazing innovations that are being done by all of you. This is the real work of the Institute to improve the lives of individuals and families living with brain health, mental health, and addiction problems. We're going to hear about some really encouraging public and private investments that we are making in actually improving the care of people living with these disorders. And finally, we're going to hear about some new efforts that we're doing with the Institute to help inspire and prepare the next generation of brain health, mental health scientists, experts, and professionals. And then we're going to finish this morning with a little networking lunch right outside here and a poster session. So that's the plan for today. I'm going to get us started now with a few brief introductions and just a little summary of what is this Institute all about. And my hope is that in a couple of minutes, we're going to be joined by Mike and Lynn Garvey, who helped found this Institute through a tremendous foundational gift not that long ago in the fall of 2019. They were planning on joining us today. I think they're running a few minutes late. So when they come, we'll stop for a second and just welcome and thank them. Okay. I also want to thank and acknowledge our Garvey Institute Community Advisory Board, Craig and Rita and Joe and Ken. You guys are all here. Thank you for joining us. And I want to thank the staff of the Institute. That's Becky and Andy and Mary and Samhar and Mike, who got us to where we are today, who are helping us do all of this really, really cool work. And a tremendous group of faculty and staff advisors. We've had a group advising us on what to do in the space of addictions, and a group that has advised us on what we do in the area of brain health and cognitive aging, and what can we do as an institute in the area of trauma. What about the area of using technology to try to improve brain health? And then finally, based on the advice of our community advisory board, we set up an additional group that is really focused on what do we do about adolescent and young adult mental health. And I just want to thank all of you who are participating as advisors. And then finally, the real work, I think, of the Institute is being done by those of you who are doing one of our innovation projects. And we've launched 3 rounds of really great innovative projects to date. I'll say a little bit more about that, and we'll hear from some of them this morning in areas such as cognitive aging, trauma, addictions, technology approaches to try to help improve brain health and mental health, and most recently, young adult and adolescent mental health. And I think the biggest, the most important introduction I can make here today is just acknowledging that there is now over 100 wonderful people working on doing the work of this Institute. And that's, I think, the real beauty of this Institute. The Institute is not a building. The Institute is something that is happening across our entire university with people from all 3 of our campuses working together to try to sort of take on this really, really difficult challenge. I'm going to come back in a minute to say a little bit more about the Institute, but I think maybe the most important introduction that I can make this morning is Anna Mari Kause, our president, our amazing president, somebody who really doesn't need an introduction. And Anna Mari knows a lot about brain health and mental health, both as a trained professional, as a professor in clinical psychology, but also as a really amazing and inspiring person and human being. So Anna Mari, if you could come up and say a few words to welcome people. Thank you.
Jürgen started saying that I knew a lot about mental health. I thought he might be going in a different direction. Although, certainly, I think, as with all of us, the last few years have been trying. And it's really wonderful to be back together, to be in community. As we all know, we are social creatures. And I think that, it was very, very challenging. One of the things that's really amazing, and Mike and Lynn, when they get here, they really, deserve a round of applause. They really are very, very visionary, very caring, very incredibly compassionate people. And when they took the extraordinary step of establishing, there you are, I was just talking about you. Talk about on cue. Lynn and Mike, I was just talking about what caring and compassionate and special people you have both been. Yes. I'm sorry. Mike. We were talking a little bit about how the pandemic, has stressed us all. And one of the things that really was remarkable is that when Mike and Lynn took the extraordinary step of establishing the Garvey Institute, that was 3 years ago. It was 2019. It was before the pandemic had really awakened so many people's sense. But even then, they knew, because quite frankly, it was already clear that we faced an acute need for behavioral and mental health services in Washington and beyond. And today, the need has only grown. And the importance of the work that they're supporting, the work that everyone in this room is doing, and those of you that are watching virtually is doing, is only more important. And I'm very grateful for this work that is building towards a future where people with mental illness, substance abuse, cognitive aging, and other brain disorders can access effective treatment, because that is so incredibly important. Lynn and Mike, your visionary work and your partnership with UW Medicine has made this possible, and you are making a difference and having an impact and helping us have an impact. So I really thank you from the bottom of my heart. Jürgen was saying, this is personal to me as a clinical psychologist. I have seen the distress, but I'll be honest, it's also personal to me as a human being. During the pandemic, someone very close to me committed suicide. Second person that I've known very closely that has done that, and that had mental health needs and were not able to access treatment, didn't know how, and when they didn't have effective treatments. I mean, this is one of the things that I think is so important, is that this isn't just, we have the smartest people in the world thinking great thoughts, but this is personal and this affects all our lives. And that's something that you have helped. Not only have you helped us in terms of the research, but you've helped us be able to all say that this is important and that this is personal, and this is about our work, but it's also about our lives. Since its creation, the Garvey Institute has already spurred discovery and innovation that's contributed to a greater understanding of brain health. A Garvey Institute Innovation Grant helped fund the research exploring how advances in AI could help people have more supportive conversations about mental health. And that's so important because we are, as much as we are committed to building the workforce of mental health, and we are committed to doing that in this state. These issues are not going to be dealt with one-on-one psychotherapy. We're never going to have that kind of workforce. And this work with AI, it's, I've actually seen the poster and talked to the people. It's very exciting. It's very exciting. And recently, Garvey Institute researchers announced the first ever opioid vaccine trial in humans in the US. That is huge. A successful vaccine could transform how we treat addiction, and it holds the potential to make serious headway against the ravages of the opioid crisis. If we think that COVID was bad, the number of lives affected and touched by the opiate crisis, the numbers are bigger, and the deaths are larger, and it continues. And somehow we haven't managed to put it front and center as a real crisis, and you're helping us do that. Innovations like this are why the Institute is not just at the forefront of brain health science, but it also embodies the UW's larger mission to create impact for the public good. Yes, we want to do basic research. Universities are the only place where that happens, but we want to take it out into the world where it can make a difference in people's lives. And it represents what's possible when private philanthropists like Lynn and Mike seek out synergies with the state and with UW Medicine to create maximum impact. This is and needs to be a team effort. And it demonstrates what a difference we can make by applying private and public investments to fuel new collaborations and attract top talent and support the top talent that we have here. And it shows what's possible when researchers, clinicians, patients, families, and whole communities are working together to create positive outcomes. Jürgen, I want to take a moment, and I know, I don't want to make you blush, but I really want to thank you for your outstanding leadership. Leadership matters, and the care that you have given to bring people together, to nurture new talent, to make sure that more established researchers are working together with newer researchers. It's really been inspirational to watch. And I wish I could be here for the full day. I do have the conference proceedings, and believe me, I will read them. This is, I care about this deeply. I hope that you all have a really productive and stimulating meeting as you hear from each other and you learn from each other. Today will be successful if 2 people walk out and a whole new collaboration starts up. That's what's so important about being together and talking together in person. The Garvey Institute is on the leading edge of brain science and a model for how a community of talented, visionary, generous people can come together to create impact at a scale and speed that once seemed impossible. I honestly, when I began my career, I remember, my mom said, "Why would you want to work with crazy people?" That was really her response when I said I wanted to be a psychologist. I think that I never thought that in my lifetime we'd see the kind of destigmatization of mental illness that we've seen. We're not 100% where we need to be, and there are parts of the country where it still is an issue, and there are populations within our community where it's still an issue. But the kinds of advances we've made, and it wouldn't be possible without brave people stepping up and saying, this is all our problem. And it's going to take all our effort to make a difference, to make an impact. So thank you all. Thank you so much to the Garveys. I mean, you know how much you've touched me with this. But thank you all for the good work that you are doing. And believe me, I am following you and I care desperately about this work. So thank you.
Wow. And thank you, Anna Marie, for your support and your leadership and your vision for what we can do as a university, as a big public university, when we put our hearts and our brains and our minds together to do this work. So I think one thing we're going to see today is what can happen when we put 100 really smart people from all 3 campuses of our university together and unleash them on a really big problem. I think that's sort of my preview of, I think, what we'll see today. And thanks to Lynn and Mike and Denise and the Garvey family for making so much of it possible. All right. So I'm going to do something really goofy because I know everybody in this room is not on the same place when it comes to when we're talking about the brain. I'm going to do a couple minutes what I'll call Brain 101. All right. And so this is going to offend a whole bunch of really smart neuroscientists in this room who are going to tell me that half of the stuff that I put up there is wrong. And we could do that later. But bottom line is that thing that you have in your skull, that 3-pound organ, that's called your brain. It takes up 2% of your body weight. It's made out of 75% out of water. That's really all it is. And it uses up 20% of your body's energy. And what's in that thing, that 3-pound thing that looks like a big sponge when you take it out? There's 100 billion little nerve cells called neurons. There's 100 billion little support cells called glia. And those cells meet each other and talk to each other, and they make 100 trillion connections. Can you imagine that? Nobody can imagine that, right? And those connections are a complex circuitry that sometimes is referred to as the connectome. And it's mostly in place when you come out, when you're born. And then it gets modified over the next 20 plus years. And it makes up by far the most complex organ that we have as human beings. And so what does this thing do? So what does a healthy brain do? It helps us process information. It helps us create consciousness and experiences. It makes us who we are as humans. It helps us create memories. It helps us solve pretty complicated problems. It controls our thoughts, our feelings, our behaviors, our actions, our speech, and it really it makes us who we are. Our personalities are all different. We're not wired the same, literally, right? So that's Brain 101. And it's what made me become a psychiatrist, because I looked at all the things that when you're in medical school, you learn about all the different parts of the body, and I'm like, that thing is the most complicated. Nobody knows how it works. That looks like a fun thing to try to take on. So anyway, and what happens when something goes wrong with your brain? Well, if that happens, you become one of the many people who are struggling with very severe mental illnesses, things like autism or schizophrenia or bipolar disorder, or maybe more common mental health problems, serious depression, anxiety, addiction. And as our brains age, we struggle with cognitive decline. We have things like Alzheimer's disease. We could have strokes, or we get involved with really risky health behaviors, alcohol use, drug use, and suicide. And that's what happens when things go wrong with our brains. And I'm not going to narrate everything on this slide, but what's the bottom line? And this is one of the things I want all of you to walk away with today. We have to be able to keep telling folks that this isn't just something that happens occasionally, rarely to somebody. This is something that happens. We now know that mental health and addiction problems will affect nearly half of the world's population at some point. And there's one big difference in this work from most everything else we do in healthcare and in medicine, and that is the cost in terms of health-related disability of mental health and addiction problems is so much greater than anything else we face. It's 5 times more than what comes from diabetes or heart disease. 15 times more disability comes from these kinds of disorders than from cancer. Now you'd say, how is that possible? Cancer is a terrible disease and people die from it. The big difference is when these problems come at us. So cancer is a very bad thing, but most of us, if we have to have cancer, we'll get that in our 60s, in our 70s. People who will live with serious brain health, mental health problems, half of us who will live with one of those disorders will have presented by the time we're 14 years old. And 75% of us will have had our first presentation, our first symptoms by the time we're 24 years old. And then you have a whole lifetime of struggling with a really disabling problem. That's why it's so much more in terms of total impact than something like cancer or heart disease or diabetes that comes at us pretty late in life. And it's not just disability, it's also a huge driver of mortality. People who are living with serious mental illnesses, if you're born in Seattle today, and you're one of the many, many people who sometime in your teenage or early 20s develops a serious mental illness, your life expectancy becomes about 53. That's like a person who was born in Bangladesh today, in one of the poorest countries we have in the world. It's a huge, huge challenge. We have a suicide in this country now every 13 minutes. We have, and this is a little out of date, I was going to say, we have somebody dying in this country from a drug overdose every 8 minutes. Actually, last year was every 6 minutes. It's been a huge increase, especially in youth deaths from drug overdoses. There's more people, as Anna Mari said, dying from this than from COVID, than from all Americans that died during the Vietnam War. We lose more people every year from these disorders than all the Americans who died during the entire Vietnam period, if you think about that. So this is a big deal. And almost every family is affected in some way. Few of us, will talk about it. More of us will talk about it now. I think when Anna Mari and I got started in this business, nobody was talking about it. And now people are talking about it. And I think that is a huge piece of progress. A couple more slides before we move on. So if you think about all the folks on this slide, if these are all the people in the United States, in Seattle, in our community who have a diagnosable mental health or addiction problem today, how many of them will see a mental health professional over the next 12 months? Well, 10% of them, about 12% of them, 1 out of 10 will see a psychiatrist in the next 12 months. And I'm going to say this to offend all the psychiatrists in the room. That's all you can do. You're going to help 1 out of 10 people. Now, there's a lot more to mental health professionals than psychiatry. There's psychologists, there's social workers, there's licensed counselors, there's chemical dependency workers. What if we said all those people together? What's the likelihood that somebody living in our community with one of these diagnosable mental health or addiction problem will see anybody for even one session? Let's include even, say, pastoral counseling, sometime over the next 12 months. 20%. 40% of people will say, I've got some help for a mental health or addiction problem from a primary care doctor. That could be a primary care doctor, a pediatrician, a nurse midwife, and 60% will get not a single session with anybody. Now, what if this was cancer? I just told you that mental health and addiction problems cause 15 times more health-related disability than cancer. What if I had to say 6 out of 10 people in Seattle who are living with cancer today will get to see any kind of professional, who's got some training to help you with your cancer? We'd find that totally unacceptable, but that is pretty much where we are in this work. And this is much of the reason why we said, that's the mission of this institute. And the vision is we will see a future where we can prevent some of these disabling disorders, where we can help people with these disorders live much, much better lives. That's what we're all working on together. And we're going to take 3 strategies. The most important one, and the one we'll talk about the most today, is serious innovation. We need out of the box, really amazing, great new ways of preventing illness, of treating illness, of helping the people who we can't treat completely live much, much better lives with these illnesses. And that's what most of the effort here is dedicated for. The second strategy, and you'll hear about that also, is we need more people to join us in helping people with these illnesses. This has not ever been the most attractive part of medicine, the most attractive part of healthcare. One of the things, that I always think about is we have many, many people in our 4-year colleges, including our own, who are studying things like psychology as undergraduates. And then, they often sometimes get the message, if you're not in the STEM field, if you're not learning how to be a computer scientist or something like that, you might come out and graduate and be a barista. Or get paid like a barista. And I'm saying we need to find jobs for people who don't have the math chops, but have the human chops, or maybe both, to be really, really effective and make a huge difference. And I think we can do a lot of smart things, if we put our minds together to do that. This doesn't come out quite right. I'm sure I offended somebody here, but I'll explain it in a little bit more detail later, because I think we have tremendous potential to draw more people into this field, to get them excited about this, to help make a huge difference. And then finally, we're using some of the resources of the Institute to help recruit to the university and retain some really amazing leading scientists who can help us, really advance big core portions of the portfolio. So a little bit about what we've done to date. We've put most of the efforts into funding a whole bunch of really neat projects that we're calling innovation grants. Almost all of you here are working on one or more of these innovation grants. These grants they are intending to fund things that can make a huge impact on brain health. They can help create collaborations, just like Anna Mari said, across the university, putting smart people who otherwise don't know each other together to do things, to take a crack at these problems that we haven't really thought about yet, things that could be rapidly translated into actual better care. And we funded 36 of these grants to date, and there are 88 university investigators who are working on these. And where are they from? All over the university. And this is the thing that I'm the most excited about. We have people from all three campuses of UW working on these projects. The grants investigators are at 9 schools and colleges in 23 departments and working with a whole bunch of local and regional partners. And from a business perspective, this maybe is a slide for Mike. I think we have invested roughly $5 million so far in these projects. And those $5 million, our really smart investigators have leveraged these projects in already in 2.5 years to generate another $25 million in funding from other funders, funders such as the National Institute on Drug Abuse, the National Institute on Mental Health, the Department of Defense, Washington State, and other partnerships. And I think that's remarkable. This is something I'd hoped we'd achieve 5 or 6 years in. I think that's what we're already seeing in the first 2 or 3 years, that there is tremendous potential. We've also generated, you all have generated a tremendous amount of media attention. This is just a little sampling of all of the great coverage that you and your projects are getting. And that's good for you, it's good for the university, and it's good for raising awareness. When the Seattle Times writes about some of this work, it's more exciting to read about that than to read about one more story of somebody being shot. So thank you for all of this great work. As I said, we're building some really neat new collaborative training programs, and I'm not going to say much about that because we'll hear about them later today. We have done some targeted recruitments, bringing some and retaining some really great scientists here. I'm going to call out Marco Pravatoni. Marco is a really neat guy. Marco, where are you? Not everybody knows. There you are, right there. Marco joined us from the University of Minnesota. He's a pharmacologist, and he's the guy that Anna Mari mentioned, who was saying, what if we could vaccinate people so they don't have to die from opioid use disorders? And he'll tell us a little bit more about that work later. Another person who has recently been awarded an endowment as a senior scientist for the Garvey Institute is Tom Grabowski. Tom, where are you? There you are. Okay, and Tom is directing the UW Memory and Brain Wellness Clinic. He's really helping focus on strategies that will promote brain wellness and help us think about how can we make our brains become and stay more resilient as we age. And you'll hear a little bit more about that work as well. We have a couple of active searches for senior faculty to join us with some of the endowed professorships that we can make available through the Institute. Say a little bit more about that later. And for now, I just want to sort of pause. I want to thank again, a huge thanks to Lynn, to Mike, to the Garvey family, to Anna Mari, to our advancement colleagues who are here, to our faculty advisors, to our advisory board, and to the team, the staff of the Garvey Institute. We really, really, really appreciate this amazing opportunity for us to put so many smart people together and to try to take a crack at this very, very, very difficult problem. So we're going to have a great morning. We're going to hear a bit more about all of these things, but that's the very big picture overview. And I know Anna Mari has to go on. So we're going to thank her and say goodbye and thank you. And anybody have any quick thoughts, questions, reactions? We good to go? Are you guys good to go? All right, very good. All right. Okay, so now we're going to turn ourselves to hearing from, as I said, I think the real work of the Garvey Institute is not the stuff I'm doing up here talking. It's 100 people who are working on one or more projects to solve these difficult problems that we're taking up. And many of you are on this slide. Not all of you are on this slide. It's hard to fit 100 people on a slide. But I really feel like this is a nice way to say, it's not one person, it's not a handful of people, it's a lot of people really working together to solve these difficult problems. And what are we working on? Every one of your projects is, taking a very unique approach to this giant problem of mental health, addiction, brain health problems. And if I try to organize my thinking about what are we doing, it's a couple of strategies that I see you doing. Some of you are about, okay, how do we improve brain health? One strategy is, can we protect the brain from getting harmed, from getting injured in the first place? And what is going to harm our brain? Trauma can harm our brain. Drugs can harm our brain. Chronic stress can harm our brain. The earlier we can get going at protecting our brains, the better. Ideally, we start that even before birth, but this is a lifelong challenge, right? To protect this 3-pound organ that is so important for us. Another approach is, could we help exercise the brain? What is it? We're exercising our bodies to keep them in shape. What is the mental health? What's the brain health equivalent of that? I put into that category all kinds of strategies. What about parent training? What about early childhood interventions? What about education? What about ways to try to keep our brains active as we age? That's another, approach. The third approach is, when the brain really breaks, when that circuitry that I talked about breaks, are there ways we can help repair that? Are there ways we can modulate it? Are there ways when our circuitry isn't working right, we can stimulate it in such a way that it does function better? And then finally, a whole bunch of strategies that are primarily focused on helping those of us who are living with these challenging brain problems, function better. And that involves using medications and psychotherapy. And Anamari mentioned technology. There is some really neat stuff where a lot of us are hearing stuff about artificial intelligence right now, and it's a little scary. It could probably do a lot of good, and it could probably also do a lot of bad. And so I think the opportunity we have there now is to say, how could we leverage that to help, in this work that we're all doing? I'll talk a little bit about new treatments such as neuromodulation treatments, and we're going to hear some, something that's also very, very important, which is it's not just the people who are living with the illness who need help. It's the families and the family members of the people who are living with the illness who need help. And that's another area that we've really given a lot of thought about. Okay, so I'm going to call up here, for a couple of very brief presentations. Not all 100 of you, but we've chosen 7 of you to come up here and spend a couple minutes and talk about the project that you're working on, just so we can get a sense of what's possible, what are some of the approaches that we're taking. And the first person I think I'm calling up is Katie, who's going to talk about the microbiome and how it relates to our brains, and in particular, people who've had brain trauma. You ready, Katie?
I'm ready.
All right. Okay, and the way to advance the slide is just push it down.
Okay,
Right.
great, thank you. Okay, so push it down. Okay, so I'm really happy to be here today to talk about this research that I conducted with my colleague, Abby Schindler. And we were really happy to receive this funding because it allowed us to combine our lines of research for the first time to conduct this study. So traumatic brain injury, or TBI, is a leading cause of disability in the United States, and it was considered the signature injury of the conflicts in Iraq and Afghanistan. Mild TBI, or MTBI, is by far the most common type of traumatic brain injury, and military members are at high risk of TBI in general. Among military members, there is a high rate of co-occurring conditions, including PTSD, pain, and sleep difficulties. And what we see in the VA is that for years post-injury, many veterans present with a range of chronic symptoms, such as those that are presented on this slide. And what we have tried to do as researchers is try to understand what is causing these symptoms, what is going on. And we've largely focused on the brain, trying to understand the functioning of the brain. And we've largely focused on that in isolation. But now we're beginning to try to think outside of that box because we're still seeing veterans experiencing these symptoms for years post-injury. And we, in our group, have largely focused on the GI system because we know that there's a connection between the brain and the GI system. And we've also noticed that veterans are reporting high rates of GI complaints. So what is the link between the gut and the brain? How many times have you heard the phrase, trust your gut? Or you've had that sensation of butterflies in your stomach when you're feeling anxious. So we've all kind of had that experience of that link between the gut and the brain. But now scientists are starting to research this gut-brain axis, which is the two-way communication between the brain and the gut microbiota. So the gut microbiota is that collection of microorganisms that live in the digestive tract. And what we now know is that alterations in that microbiota are associated with things like depression, anxiety, reduced sleep, and poor cognition. So that made us wonder, in these veterans who are having increased rates of GI conditions, could changes in the gut microbiome be contributing to these persistent symptoms that they're experiencing after MTBI? And that's the pilot study that we conducted. So we were doing this during the pandemic at a time where we couldn't do in-person visits. So what we wanted to figure out was, could we do this study completely remotely and collect the data? And could we find a connection between gut microbiome and these persisting symptoms? So we asked participants to do at-home fecal tests to look at the microbiome. And we also asked them to do self-report questionnaires of all of these symptoms online. We had a very enthusiastic response from the people we reached out to. We were able to enroll 26 participants, and they completed all of these measures, sent the at-home fecal test back to us, completed the questionnaires online, and similar to what we were seeing in clinic, we had very high rates of PTSD symptoms, depression symptoms, cognitive difficulties, sleep difficulties, and pain symptoms reported. These are the results that we got. This is a heat map. And the important thing to take away from this is that the darker color on the map indicates a stronger relationship among the symptoms and the bacteria in the gut. I'm going to show this a different way that really illustrates what we're trying to show here, is that the majority of the symptoms that were reported by the veterans in our sample were correlated with changes in the gut microbiome. So change or elevated symptoms in mood, pain, cognitive difficulties, as well as some substance use symptoms were all associated with different aspects of the microbiome in our sample. So this was the first evidence that we're aware of a connection between chronic symptoms and gut microbiome in veterans who screened positive for a possible MTB. This was really exciting for us because it opens the doors for a possible new intervention. There is evidence out there that if you can change the gut microbiome with a simple intervention like a probiotic, that you can reduce symptoms. So in other populations, things like depression, anxiety, cognition, and sleep quality have all been improved. So that is the avenue that we are considering as a next step. We are hoping to publish or submit this manuscript for publication in the next couple of weeks. And we want to thank the Garvey Institute for the funding, which allowed us to do this work, and also to acknowledge the rest of our research team. Yeah.
Do we have time for questions?
Okay. Absolutely. So we asked a lot of questions about diet as well, and that is one of the things that we'll be looking at in more detail as we think about our next steps.
I just wanted to comment on what a great collaboration this is between people from psychiatry, psychology, basic neuroscience, and so it brings a lot of strengths together.
Yeah, thank you.
Yay. It is a really great collaboration. It's a really out of the box idea. If you had told me when I was in medical school almost 30 years ago that what is in our gut and what we eat is going to affect how I feel, how I think, I would have said you're probably smoking something that's not good for you in the long run. But it turns out, so this is a really great example of some real out of the box thinking, but really good high quality science. And it'll be super cool to see where this goes. The next presentation, all right, come on down. And that's Sunny, who's going to talk to us about a really neat project called Psychosis iReach.
Good morning, everyone. My name is Sunny Chen. On behalf of Psychosis iReach team, it is really an honor to be invited to share with you how we leverage technology to support family caregivers navigating severe mental illness. The reason why we devote our efforts on supporting family caregivers is because families are often the unpaid shadow mental health care workforce. A lot of them didn't have the experience or the expert guidance on how to take care of their loved ones managing symptoms. Although there are many effective family interventions out there, based on this national data, less than 2% of the 60 million family caregivers can access any intervention. One of the most important, effective and evidence-based intervention is called Psychosis Reach, which is developed here at the University of Washington Medicine by our lead researcher, Dr. Sarah Koplovich, who is on the call with us today. Research has shown Psychosis Reach can effectively support family caregivers by delivering expert guidance on psychosis communication skills, problem-solving skills, and coping skills. And we want to bring these evidence-based and effective interventions directly to families. And we know technology can help us to enhance access even more. That's why we are so grateful for Garvey's generous support and resources for us to develop a digital tool called Psychosis iReach, where family members can access Psychosis Reach training wherever they are and whenever they need. We work closely with family caregivers who have loved ones diagnosed with bipolar disorders or schizophrenia spectrum disorders. We work closely with them and ask them, what do you need? What did you struggle with? And how do you want to see a digital tool to help you? And family caregivers help us to design several features on the platform, including a website where they can learn about Psychosis Reach skills at their own pace. We also design and develop a simulated loved one called Alfie, whose family caregivers can practice what they learn from the website directly on communicating with Alfie. And in the end of each conversation and practice, expert feedback, excuse me, will pop up on the screen to debrief with them how well they did and what are the additional evidence-based skills they can consider to use. Our team wants to make sure that the platform is family-centered. It's from their perspectives, not from researchers' perspectives. So from multiple interviews, we transform family caregivers' feedback into the core design guiding principles for our work. First of all, the platform needs to be simple and easy to navigate. And also the content needs to be usable, accessible. And they want a place that's private and also low risk for them to apply the skills they learn. a lot of family caregivers told us that being as part of this online community bring them the sense of belongings, and knowing that there's resources out there available for them brings them hope. After multiple iteration process, we also pilot tested it about the acceptability, usability. And these are some of the feedback families gave us. First of all, because of the succinct and clean outline of the website, they think the website is simple and very with the with the different materials that's included in the website. The website is very engaging. Also, they especially appreciate the expert feedback for their practice with Alfie. It really takes several villages for us to conduct all of the work. With the funding, we were able to work across 3 UW campuses and among different disciplines, including psychiatry, nursing, human-centered design and engineering, as well as computer science. But we know there are more work for us to do. So our ultimate goal is to design and develop a conversational artificial intelligence tool, just like virtual agents or chatbots or Alexa at your house, where you can have a tool at your fingertips whenever you want to know how to talk to a person that you care about who is impacted by mental health conditions. To achieve this goal, as we keep, because we believe that as we keep the conversation going, the stigma of mental illness can be broken down. There are 2 immediate steps that we need to take to accomplish this goal for developing an AI tool. First, we will build out a recording function on the website where the conversations and interactions between family caregivers and the simulated loved one, Alfie, can be recorded. And the recorded conversations will become the essential data for the machine to learn how to better deliver a tailored, empathetic, and just-in-time feedback for the family caregivers. Secondly, we are in the process of vetting AI companies or people who are interested in joining us and support us to do this work to accomplish our ultimate goal, AI tool. If you are interested in supporting our work, here are 2 contact information for Dr. Koplovich and David, Director of Philanthropy. Again, we are very, very grateful for the funding support. Without this funding, we cannot accomplish our goal to support more and more families who are struggling and who are in need of navigating severe mental illness. Thank you very much. Yes, over here and over there.
Go for it, Rick.
Yes, very interested. Have you done any pre-work on the AI chat box kind of interaction? Yeah, I'm just wondering, in a family that's like struggling with things, how they relate to an AI voice versus a human picture of a person. Another stuff is the personal link or the information link that's important here.
So that's a very thoughtful comment. So a lot of family caregivers also express the same need. So that's why when we develop the simulated loved one, we ask them to choose different pictures that we want to see on the platform. And also, as you can see from the slides, they also prefer the real image of the expert who provide them the comments. So we want to humanize the AI tool as much as we can. I hope that answers your question. Of course.
So Sunny, I'm gonna keep moving. Sunny, thank you. Another out of the box, really cool thing. Again, even 10 years ago, I'm like, I could have never thought of this. But think about it. It takes those of us who work in this field, probably a decade or 2 or 3 to get good at talking with people living with, psychotic mental illness, delusions. And when we get okay at it, we're not very good at telling family members how to talk to their loved ones. One of the things they say to us is, "What do I say? How do I not get into an argument all the time?" Those are basic things that millions of people could benefit from. And if you can learn and rehearse that using a tool like this, we can scale it, because it would take us years and years and years to take all of these skills and teach them one-on-one from person to person. So again, out of the box has a ton of potential, and I really thank you for doing this work. All right, keep us going here. All right, now we're going to move to a really tough problem, and a problem that has gotten worse during the pandemic, and that is really a whole epidemic of youth suicide. And I'm going to invite up Denise to talk a little bit about how they will take a crack at this, working with our colleagues in primary care.
Hi, good morning. Thank you for having me today. My name is Denise Chang, and I'm here representing our newly awarded grant for this year, which is addressing suicide risk in primary care to reduce youth suicide. So not a surprise, I think, to anyone in this room, but suicide is a major public health concern. It's in 2020 alone, it was the 12th leading cause of death overall in the United States, but a leading cause of death for youth aged 10 to 24. So as you can see from this alarming graphic, the suicide rates in youth have been increasing and have been actually surpassing homicide rates in the last decade. And nearly half of the youth that die by suicide contact a primary care provider within 1 month prior to suicide. So we know screening adolescents for suicidal thoughts and behaviors can help identify those at risk, and national guidelines actually recommend all medical settings actually screen for suicide risk. But yet we know that there are several barriers that exist to implementing suicide screening and prevention, including lack of infrastructure and training. So our project is to develop a suicide prevention program for youth with suicidal thoughts and or behaviors, one that can be efficiently and effectively delivered in primary care. And our Garvey grant will help support the development of a comprehensive suicide prevention program that will encompass this whole continuum of care. So that includes screening, assessment and intervention, and triage. And triage is to help connect patients with resources and or referrals. In the primary care setting, there may already be some type of screening in place or triage in place. And in that case, our team hopes to help optimize and standardize those workflows for those clinics. But where we really hope to focus on is to this middle section, the assessment and intervention. And that's where we plan to develop a brief suicide risk assessment and intervention strategy. So talking about what that assessment and intervention is, so our goal is to take an evidence-based suicide intervention model that was initially developed for the emergency room and adapt it for use in primary care. And we hope to involve both master's level and bachelor's level clinicians so that we can expand the behavioral health workforce that can provide this kind of care to our population. We also chose a model that helps emphasize patients' strengths and involves parents and caregivers as a part of that support system. But the process in which we do this plan and this project is just as important as the goal itself. And by that, I mean, we really want to engage key stakeholders, the providers themselves that are doing this work, the teens, the parents and caregivers in developing this intervention in order to create a patient-centered model of care. We, of course, want to provide training and evaluation for clinicians that are going to deliver this intervention. And we're going to all along the way get feedback from everyone involved, providers, the youth themselves, and parents and caregivers. So in summary, as we take on this challenge of developing a comprehensive model of suicide care for adolescents in primary care, we hope to make a big impact. And we want to do that by expanding access, of course, to these critical services and expanding the behavioral health workforce that can provide that care. We hope to reduce risk for adolescent suicide and enhance patient safety. And we want to reduce the burden on our already very busy primary care colleagues and reduce unnecessary referrals to the emergency room and ultimately create a sustainable and scalable intervention for primary care. So with this project and the data that we'll gather from this work, we hope to eventually use it to expand our efforts to improve patient safety and outcomes, and then also apply for subsequent funding that can help test and potentially increase the scalability and effectiveness of a suicide prevention program like this one. and then hopefully advocate for expansion of reimbursement opportunities for these types of services. So I'll just highlight the team on this is our wonderful project team, including my co-lead on this project, Dr. Sarah Danzo, who's here today, and our other amazing talented group of co-investigators and collaborators in this list. I won't name them all, but this group includes clinicians like myself from the UW Department of Psychiatry and Behavioral Sciences, our clinical experts from Seattle Children's Hospital, and of course our clinical partners at UW Medicine Primary Care. And of course, a big thank you to the Garveys and the Garvey Institute for supporting this work. Our big appreciation for being able to do this work in our population. Any questions? No questions. Thank you.
See behind me. Denise, thank you. This is a brand new thing. This just got funded, so we don't have anything results to show you, but it's a really important project. It's a tremendous opportunity, and if you talk to our colleagues in primary care, pediatricians, other healthcare providers that see young adults and youth, they know this is an opportunity, but it's also a scary thing for them, because what do you do when you ask somebody, you ever thought about hurting yourself or killing yourself? That's a hard question to ask, and then what happens, right? And that's, I think, what you guys are going to develop, a way for them to say, this isn't the most scary thing I have to do in my day. This is something that actually could make a big difference. And I now have the tools, the skills to actually have that conversation. So that's not super high-tech AI stuff like what we saw. It's very human, and it's very important because it's something that people really aren't very well equipped to do. So thank you for doing this work. We're going to actually stick with this really tough challenge of suicide. And I'm going to ask Rick Reese, who's the director of our Division of Addiction Psychiatry, to come up and talk about a very focused approach to helping people who are at very high risk for suicide because they're struggling with an addiction. So, Rick.
Thank you, and thank you to the Garveys and for all of you attending. So this says innovative training and implementation for suicide prevention and addiction treatment settings, the PARS web project. So already we've learned that Garvey can fund something pilot, like what about this problem? Let's sort of define a little bit and then take that and go for a big grant. And then we've learned from Sunny Cheng and Sarah Koplovich that there's some interventions here that have been shown how to work, but how do we get them out there? And as I've sort of looked at what the Garveys are doing here, we're not talking about the $5 million grants to do validation of a concept. We're talking about pilot stuff here, but what about this dissemination stuff there? And so that's where kind of our project fits in. If you have an addiction disorder, you have about 10 times a chance of killing yourself compared to the general population. Interestingly, as probably people know, suicide's always been thought of as, well, that's mental health. The addiction stuff goes over here. So things are siloed out. And by scope of practice, chemical dependency counselors that work in addiction treatments are unable to treat acute suicide. So what happens at the front door if somebody comes in with acute suicide? They say, go over here to mental health and do something about it and maybe come back later. But what about suicide prevention in a population that is at super high risk? So it's like going to South America and discovering this whole group of people is at risk for yellow fever. Maybe we should give them inoculations. So that's where our project came in. The PARS project was developed by our group 12 years ago with a pilot study and then a very large randomized control study done in 15 different addiction centers in the Northwest here from Tacoma clear down to or up to Everett area. And we enrolled 100 counselors from 15 different centers, and we intervened with 900 patients, and we published the outcome study. But what do you do with a study that shows that it might make a difference? How do you get it out there? And so what we applied to the Garvey Institute about was we want to develop a training website because our intervention was PowerPoint based, and not only give people PowerPoints and like how to do it, we said, well, what about doing real groups and doing interventions, watching the expert, that was me, because I trained all the people in the grant, doing video shortcuts of parts of the intervention around dicey things, like the fifth slide in the PARS intervention says, do you know somebody close to you who committed suicide or nearly died of suicide related to drugs or not? And that's a very profound thing that happens in the group. Now, turns out that about 80% of all the billings for community addiction treatment centers are for group therapy sessions. That's the way most addiction treatment happens outside of methadone centers, is group therapy, where people get around and they're led by a group. It's about a 3-hour group. It happens 3 times a week, happens for about 3 months, and then it decreases in frequency. So it's an ideal time to actually say, how do we intervene with something? We can intervene something in a group. And so that's how we did the study. So the Garvey has funded the ability to take this intervention, create a training website it trains people not only by telling them what to do, not only by showing PowerPoints, but by integrating video interventions of how you actually do it and how do you handle kind of dicey things that might develop in the group. And then at the end of it, it gives you certification, et cetera. So the website develops certification, billing, et cetera. Why billing? Because in order to keep a website up and change things like data about suicide, you need to have an infrastructure that continues to make itself happen. Many people know you go to certain websites and the last time it was updated was 10 years ago, and you go, this doesn't make sense anymore. So we have that as part of it. We copyrighted the materials through co-motion, which is another part of the university. Why did we do that? Because what happens to a lot of interventions is they get out there, they're tested. You're supposed to do X, Y, Z as part of the intervention. It gets out in the community and people do X and Y. They don't do Z, because they just take parts of this and parts of that. And so what's an evidence-based intervention isn't evidence-based anymore. So we've created the website to manage a lot of that kind of dispersion. And that's in process right now. We've developed the website, we've developed all the integrated videos. We've worked with the AIM Center, with Alan Goydick, to develop this website. And that's a combination there of the AIM Center at the university in our department and the CSPAR, which is the Center for for Suicide Prevention and Research. We've presented it at a national meeting, the American Academy of Addiction Psychiatry. We'll also be presenting it at the meeting that we're having in about 4 months with all the addiction administrators and people who own addiction sites in the Washington state. They'll be there and they're going to get a 3-hour training in all of it. About 2,000 or 2,500,000 people get intensive outpatient programming addiction treatment per year in the United States. Our goal is to make this happen as a standard part of addiction care. Right now, there is absolutely nothing. And this is the only intervention that's ever been developed with centers, interactive with centers, shown that it fits centers. By the way, the counselors who did it loved it. They said it was the best thing they had in their whole spectrum of things. And we've involved state legislators. Tina Orwell and Lauren Davis are former mental health people who work in our legislature, and they're going to advocate for this to become a standard part of training for suicide prevention. Thank you.
Thoughts, comments for Rick, questions? Yeah.
All right, Sunny.
Well, luckily I work with a team. That's how. So we have done some of that in CSPAR with Kate Comtois and I work together on a lot of this. And she has developed some training and certification and billing through dialectical behavioral therapy training. And so we're taking that and kind of moving it into some of the next step of that.
So I think one of the things that you can start to see is the projects we're supporting are spanning a whole spectrum from very early discovery of what could be the problem. So does the gut and the brain, does that connection, is that actually the problem, to all the way downstream? Now we have a solution, but nobody's using it. And I think we got to do all of these things. And, that's another way in which we could organize the Garvey Institute projects. Are they early discovery? Are they trying something for the first time and making the case that it works? Or are they, we now know what to do, but nobody's doing it. And if we did it, we could make a huge difference in a lot of people's lives. So this is a really great example, Rick, of the latter. Okay. All right. Okay, Michelle, you're up next. Michelle is going to talk to us about, there are some things we know how to do. This is, I think, another example of that. But a lot of people need help to figure out, how do I do it? How do I learn it? And you guys are doing something really amazing to do that. So tell us about it.
Thank you. Good morning. Oh, I knew I should have worn heels. Apologize. Is it picking up? Okay. Thank you. Good morning. I'm Michelle Bedard-Gilligan, and I'm so pleased to be here today and honored to present among my amazing and brilliant colleagues. So I'm going to be presenting on behalf of myself and my co-director, Kristen Lindgren, who's here today, on our project, Increasing Access to Evidence-Based and Culturally Responsive Trauma-Focused Treatments, a collaboration with Washington State community mental health providers. Kristen and I are co-directors of the Trauma Recovery and Resilience Innovations Program, where our mission is to research and understand reactions, both adaptive and maladaptive, to traumatic and difficult life experiences, with the goal of ultimately improving recovery for as many affected individuals as possible. Our focus is really on improving treatment and recovery options and making them more accessible. And we're really excited to share the Garvey funded project that we've been doing, which is a great illustration of the TRI mission. It's exactly in line with what is most meaningful to us. Trauma exposure is unfortunately incredibly common and also has documented and far-reaching negative effects on mental health. And we have really good quality treatments that can help alleviate these negative consequences and promote well-being. The problem is that, like we've heard from many other people earlier today, we have an access problem. So although these treatments exist, we have difficulty getting them out to the people who need them most, particularly patients who are in marginalized and underserved communities. There are a number of explanations for the access problem we have, a number of barriers that exist. On the patient level, we just see an overwhelming and astounding number of patients that need care. And this leads to really long waits and confusing referral systems where patients have difficulty even understanding how to access the specialized treatments that would help them. In addition, we have problems in that many of these specialized treatments don't exist locally. So they're not embedded in the communities where patients who need them live, reside, and exist, right? On the provider side, we hear barriers such as a lack of specialized training. So providers will often report that they don't feel adequately trained in the evidence-based approaches that are needed to really promote well-being following trauma exposure. In addition, providers will report low confidence and low self-efficacy in their ability to deliver these treatments in both an evidence-based way and a culturally responsive way. And then finally, providers will often report difficulty accessing the support and consultation that they feel they need to be able to do trauma-informed therapies or trauma-informed mental health work. Working with trauma survivors is hard. It's hard on the patients, but it's also hard on the providers. And many providers will report that within the systems that they practice, they don't feel like they have the adequate supports. And so what we did was develop a virtual learning collaborative to try to better support Washington State community providers. And so we used an evidence-based model of consultation called an ECHO model that has never, to our knowledge, been used to advance the dissemination of trauma-specific therapies. What the ECHO model really does is it focuses on bringing together virtually subject matter or academic experts in the field with frontline community providers. And the idea is to bring them together and facilitate a bi-directional sharing of information, sharing of knowledge and sharing of case consultation to build a supportive environment where people can learn from each other. And then this should, in theory, trickle down to the patient. So this should improve patient outcomes because these providers are better equipped and better supported and providing better care to the patients who really need it. So our trauma recovery echo clinic was conducted across Washington state. We recruited 32 clinicians to participate in our pilot from 13 zip codes in 9 counties, representing both urban and rural areas of the state. We provided 12 sessions of the echo consultation model delivered over 6 months. And we demonstrated excellent attendance, engagement, and retention of our providers. So the large majority of our providers attended most, if not all, of the sessions that we held. We also found from our pilot data that we were able to meaningfully support both providers and patients with the ECHO model we built. So some of the clinician perspectives on the ECHO clinic that I want to share, these are some quotes from our providers. It was helpful to know I wasn't alone with some of the difficult cases I have. I really appreciated the community and the connection, and having a space to talk about the nuances and difficulties of trauma treatment. Of note, the providers actually wanted to keep the ECHO clinic going after it was done. So Kristen and I helped facilitate an online space where they could continue to connect even after the official consultation clinic was done. And I think this really speaks to the knowledge and the support that the providers felt like they got from the clinic, which was our goal. In terms of patient benefits, providers were asked to think about patients that were relevant to the ECHO consultation clinic and collect some outcomes on them. And what we found was that almost 90% of providers said that the patients that they were using skills learned in the ECHO on were using the therapy skills that they taught them. So they were using the things that they were doing in session that they learned from the ECHO. And again, almost 90% of providers said that those same patients were making progress, that they were moving toward their goals, suggesting that we really were able to achieve the trickle down to patients that we were hoping for. So in summary, our trauma recovery ECHO, like I said, it was the first ECHO clinic that we know of to specifically be geared towards providers working with mental health following trauma. We demonstrated really strong interest and follow through from our community providers across the state and achieved high satisfaction and high ratings of support and knowledge. Our next steps, we are in the process of publishing the data that we have. It may or may not be sitting on my desk, waiting for me to get to it, but it will happen very soon. In addition, some of our next steps are to use some of the provider feedback that we got. You got feedback on curriculum and timing and other kind of structural things that we could use to develop and test future iterations more geared towards specific provider types or specific trauma exposed patients. And we're looking actively for partners that have an interest in supporting the mental health workforce to help increase this reach. So finally, I just want to end with sincere gratitude and appreciation to the Garvey Institute and UW Medicine for the support around doing this work. I want to thank the community clinicians who are willing to enroll and do our pilot with us. And then as always, I just want to acknowledge the brave patients who are willing to come in, engage in services, which is a really difficult and challenging thing to do. And they trust us with that every day. And for that, I'm grateful. And then finally, Kristen and I were the directors of the project, but we had a whole team that worked on this together. So I want to acknowledge our team members, staff, and faculty across the UW Medicine, Harborview, UW Medicine Psychiatry, the VA. We had social work and psychiatry and psychology represented, and it made all the difference. I'm really grateful for working with such amazing people. And with that, I will take questions. So thank you. Maria. Yeah, that's a great question. So Maria's question was about whether or not the clinicians had trauma training already and whether we based our curriculum on that. Actually, we had a wide range. So we have data on that. It's in the paper that's sitting on my desk. But there was a wide range in terms of how much training people had. Generally, what people had were things like workshops or one-day trainings. Very few had sort of any kind of ongoing in-depth training, and almost no one really had any ongoing consultation or support that was available to them. The curriculum we went after this time was pretty broad-based, and so it actually was trying to reach all people regardless of their level of training, but that might be something we would think about going forward, is whether or not kind of tailoring the curriculum to certain skill levels might be a way to go. So definitely something we're considering. Yeah. And we're so grateful to have so many people at the UW who do this kind of work that we're gonna be asking lots of questions to as we move forward. I'm out of time. All right, thank you very
for
much.
sharing. All right, just one really brief comment. So when a person experienced serious trauma, any kind of trauma, and develops, some version of what we call post-traumatic stress disorder, it's a terribly disabling thing. And we have a handful of people in our department, psychologists like Kristen and Michelle and Emily and a few others who are truly magicians with this. I can send a patient like that who struggled for their entire life to have 8 or 10 or 12 sessions of really good evidence-based psychotherapy, and they come back and they're a different person. It's the most amazing thing I've ever seen, frankly, in my work in psychiatry. And so that's really great. But the problem is all of the other healthcare professionals out there who are seeing those patients who don't have those skills, how do we get it out there? So this is another really wonderful example of thinking out of the box and thinking, how do we take this to scale? How do we help other people do this? Because you can do it really well and you can do it really poorly, or you can just fumble like I. Then fortunately, I'm fortunate to have you guys in my back pocket when I see a person like that. Anyway, so now we're going to make a big switch and go way upstream. And we're going to talk about what we can do for people, for people's mental health who haven't even been born yet. So Amrita Bhatt is going to talk to us a little bit about a really cool project to intervene very early on in life.
Thank you. Good morning. It's great to be here. My name is Amrita Bhatt. I'm an assistant professor in the Department of Psychiatry, and I'm here to present on our project, Texting to Support Maternal Wellbeing in the Perinatal Period. Here is the team that makes this work happen. Some of them are here in person, some of them are online. Deborah Glazer, our project coordinator, Joanne Curre, Red Cap Maven, Jamie Adachi, program manager, Doug Russell, COI, and our wonderful partners from Nurture Northwest, Jennifer is here. We also had several people who helped get the word out about this project, Northwest Hospital and several different parenting and birthing professional listservs that I wanted to thank. And of course, thank you to the Garvey Institute for Brain Health Solutions for funding this work. So the problem that we were trying to address with our project is that of perinatal depression and anxiety, which is depression and anxiety that occurs during pregnancy and up to 1 year postpartum. And contrary to the common myth of the pregnancy glow and that pregnancy is protective of mental health problems, depression and anxiety is actually pretty common during pregnancy and postpartum. So if you look at those numbers, it's actually more common than what we think of as common complications of pregnancy, right? So like hypertension in pregnancy or gestational diabetes. Common mental disorders are actually more common than these pregnancy complications. And the impact of depression and anxiety in pregnancy and postpartum extends beyond the person experiencing these symptoms to the child, right? So like Jürgen said, this is the earliest point in time at which risk for mental health disorders is transmitted. Babies born to parents with depression and anxiety have higher rates of preterm birth, low birth weight, cognitive, emotional, and developmental delays, and anxiety and depression themselves. Unfortunately, despite this impact, very few people receive adequate treatment for depression and anxiety during pregnancy. We've heard a lot about the limitations in workforce, and there are also very specific barriers for people accessing care when they're pregnant or postpartum. Here are some quotes from patients who were experiencing depression and anxiety when they were pregnant or when they just had a baby. I'll read some of them out to you. So one of the patients said, so they would say, talking about her family, they would say, be strong, or, you know, it's your hormones, or you're about to have a baby. Aren't you nesting, having fun? And then from someone who just had a baby, it's that whole, oh crap, it's out of me. What do I do with it now? Where is that manual for the baby? And she's had a couple of bouts where she just cries, and I don't know why. And I think it irritates me, and then I feel super bad. And then it would just make me feel even worse about myself. What am I doing wrong? Am I just failing at this? So you can hear a lot of concerns and questions and need for support from these parents who are experiencing these symptoms. And that is what we were trying to address with this project. is to improve access to emotional support during pregnancy and postpartum. And what better way to do this than through text messaging, where one person can reach multiple people? And this became especially important in the context of the pandemic. So our partners in doing this work were Nurture Northwest. They're a nonprofit that trains peer mentors, so people who have actually had the lived experience of pregnancy and postpartum. And they match each mentor with 10, they call them members, with 10 people who are pregnant or postpartum. And there is a connection that's made. And throughout that perinatal period, text messages are exchanged, providing support and information. And here are some prompts or conversation starters that the peer mentors use in supporting their members. I won't read all of them to you, but the first one there is, have you ever experienced two conflicting feelings at once? This is common and a big part of the transition to parenthood. So a lot of information giving and normalizing that happens between the mentor and the member. And if you would like to learn more about Nurture Northwest, please connect with Jennifer later. She's here today. So far in this ongoing project, we have 127 participants enrolled. We've completed data collection for the baseline 6 weeks postpartum, 3 months postpartum, and 6-month postpartum time points. So these participants are all randomly assigned to either receive the Nurture Northwest intervention or to receive an automated text messaging. So this kind of will begin to answer the question about, well, it's good to have automation and AI, and we can probably increase access a whole lot more. But what about that piece about human connection, and how important is that? And through this text messaging project, we're hoping to increase accessible, acceptable perinatal support. We don't have the full data yet. That'll happen in the spring. But here's some preliminary feedback, which has been very positive. So some quotes from members who are receiving these text messages from Nurture Northwest. I have a great network of friends that are moms that I can always reach out to. But what I enjoy the most about your program is the anonymous piece. Sometimes I'm embarrassed to ask a friend something personal or admit something to a friend that might make me look bad. And I know there'll be no judgment here. And another unique aspect of Nurture Northwest is that members can themselves be trained to become mentors, so that they can help other people. And here is a quote from a member who then became a mentor. I was a member who really struggled in the newborn phase. As I remind them, that's the members, them all, to celebrate the wins and know that they did nothing wrong when things are hard and that they're still a great parent, I'm reinforcing that message for myself. So next steps for this project, we'd like to disseminate this further, compare the effectiveness of peer mentor texting and automated texting. It would be great if we could integrate this into regular prenatal care so that all people receive this kind of support during their pregnancy. And there is a long overdue attention being paid to maternal mental health, both at the local and national level, and we'd like to build on this growing momentum. So thank you again. Any questions?
Okay, so way far upstream, and not all technology has to be super crazy fancy AI technology. Sometimes a telephone or a text message, is something we could use to do some really, really important stuff. Especially during the pandemic. It's actually remarkable what people were able to do, keeping in touch with each other using just a straight up telephone or text message. So thank you. Great work. And then last but not least, we're going to hear a bit of an update on the investment that the Institute has made in bringing Marco Pravatoni here to help us build a really cool research program that is doing some pretty interesting things, like, could you take a vaccine to help you with your drug abuse problem? Could you take a little molecule that would help you with that? And Marco's going to tell us how he's going about that.
Well, thank you, Jürgen, for the nice introduction, and thank you to the Garvey family, like, to actually make this possible, and for your vision to kind of, essentially believe that these things actually can work. And so here, I'm going to talk a little bit about our center and what has been happening in the last year. And on a personal note, I've been in Seattle for the past year and has been great. So our mission is to advance solutions for substance use disorders and overdose from discovery to clinical stage. Some of these solutions are not meant to replace like existing therapies, but rather provide physicians and patients like with other tools to actually help in treating patients. And so we have a pipeline that stems like from our work, and that's sort of the core of the center. And this pipeline of so-called like products like spans from biologics, small molecule pharmacotherapies, device, and biomarkers. Our core technology has been around development of vaccines and monoclonal antibodies. That's what we are known for, and we spent the last decade or so working on. And just like as in this cartoon, like if somebody is being given the vaccine or the monoclonal, the antibodies will selectively counteract the drug of interest, say fentanyl, and prevent fentanyl from reaching the brain and causing toxicity such as overdose. So these programs go anywhere like from preclinical to clinical. So we have developed vaccines against heroin, oxycodone, fentanyl analogs, and some of this have reached like clinical trial stage. So we are currently doing a clinical trial of an oxycodone vaccine that I started about like 10 years ago when oxycodone was like the culprit of overdose deaths in the United States. And then now obviously it's fentanyl. And so now we have filing with the IND filing with the FDA to actually initiate clinical trials of vaccines for heroin and fentanyl. We're also developing monoclonals as like a way to rescue from overdose. And then we have a number of other programs that are at earlier stage. For example, we are developing next generation Narcan, so to speak, with new features added that hopefully will provide like additional benefits. And then also we are interested in providing other point of care tools such as sensor, for instance, for detecting opioids and other drug of interest. To do so, we have to create an end-to-end platform and the logistics, the infrastructure to actually make this happen. And so obviously we have the science, but also we have to partner with like multiple institutions, also I would say like private contractors or industry partners. And we're always out there like seeking potential licensing or partnership with pharma. And then we have to develop our own regulatory expertise so that all of this like can actually happen, moving from preclinical, so mice and rats, to all the way like to clinical infrastructure takes an army of people. And then obviously we are very much interested in commercialization because otherwise these things will never see actual patients. As far as like 2022, since we have been here like at UW, we've been successful in securing more funding from that initial investment of the Garvey Foundation. Specifically, I want to highlight like two programs. One, we've been funded, I guess, 2-3 months ago from NIDA to develop a monoclonal antibody all the way to clinical trials, and the funding will essentially support all the manufacturing, actually provide like clinical grade material, and then essentially provide all the support for filing with the FDA an IND that will enable like 2 clinical trials to show preliminary safety and efficacy of that approach to reverse overdose. And the other one, we secure like funding to move our fentanyl vaccine all the way to IND. And now we also are preparing for IND filing and clinical trials. And then since, as I mentioned, I've been here like for a year, I spent my year, and thanks to the psychiatry like department administrators help us like to move all our awards from our former affiliation in Minnesota to the University of Washington. As far as outreach, we try to stay out there like to show what we are doing, but also trying to find new collaborators, new partners, and so forth. And so we do a lot of advocacy. I've been involved like in legislation and sort of policy making, like in Capitol Hill, like some of the bills related to mental health or scheduling of like fentanyl and legislation related to that. And obviously we go to conferences and meetings, and we publish like anybody else. Like it's been great to see other colleagues like what they're doing. And then obviously we are involved like with the press, like not so much to showcase, but also to kind of be out there and let people know what we are doing, I guess. And then as other mentions before me, like takes an army to do, or a village, or however you want to describe. Like, so we have like finally our laboratory up here is up and running at Harborview. We spent the best part of this year recruiting junior scientists, recruiting like junior faculty. We have our amazing research manager, Margaret Calhoun, Dr. Calhoun, that was like the first employee number 1 here in Seattle, that helped like hiring pretty much everybody else. And then we still have our own, my former lab, we still have a lab in Minnesota. And so some of these people, you can see them in both pictures. Some, like, I convinced them to move to Seattle. So others are still back in Minneapolis, but we're still working, and thanks to Zoom, we see each other every day. And then we are developing, or I guess we have developed a consortium to make this happening. Like, we have multiple partnerships with different universities in the United States and abroad. And each of those are essentially playing like a part in moving forward our vaccines and other medications. So thank you for the time. Thank you for your generous gift, and thank you for your leadership. So I'm happy to take any questions.
Yeah, hi, Marco, thank you. I know there's like a dozen or more analogs of fentanyl. And when you develop a I know you mentioned analogs there, but when you develop a vaccine, how many of those analogs does one get before you run out of effectiveness there, or is there any way to know that?
That's a very good question. I don't think there is any way to know that, because essentially people will keep making like new analogs. But when we screen for these vaccines, we try to build it so that we'll catch like most of the major ones. Some things like fentanyl, acetylfentanyl pretty much will never go away. Other like crazy compounds like butyryl, fentanyl, methyl, fentanyl, those would pretty much like disappear. And so we try to go at least after like the major ones that are involved in overdose and potential risk of exposure. So thank you.
Okay, thank you, Marco. So this is a very big, robust effort that's gotten a fabulous start in a very short time, a year or two, and we'll be excited to see where you go with it. We're going to switch gears a little bit. We've heard a bunch of stuff about really neat new things we can do. And now I'm going to try to address the question of, okay, that's all really cool. And maybe in 5 or 10 years, we'll have all these really neat new things. But what are we going to do right now? There are so many people who need help right now. And so I'm going to switch gears a little bit. And the next couple of presentations are going to try to really go after that. And if anybody needs to step out, feel free to use the restroom. We're going to go 5 or 6 more short little talks here, and then we're going to do an actual break. So totally up to you. I don't want to make anybody uncomfortable. All right. So one of the points I will make before I call up a couple more presenters is having a big investment like this, a tremendous foundational gift like this, can be a real catalyst for growth. And what I would say is, we got this tremendous, shot in the arm, whatever you want to call it, to stand up this institute, to bring together so many smart people to work on this problem. And word gets out about that, and people start paying attention to it, and people start saying, what can other people do to try to help with this? So I think, what we have seen just in the last couple of years is a tremendous, both public and private investments in this area that we had never really seen before. So we have seen growth in our outpatient clinic, and Amanda will talk a little bit about this just this year, almost doubling our visits in almost 2 years. We're getting ready to put up a brand new 150-bed behavioral health teaching facility. We got $250 million from the state of Washington on the UWMC Northwest campus. We are, a little bit further down the road, going to be working with our colleagues at Harborview, who've raised over $1 billion in tax funding for a bond to try to make improvements on the Harborview campus. And a big part of that will be a new behavioral health institute. And then we're also partnering with our colleagues at Seattle Children's Hospital that have a great vision of building new programming down in South King County in Renton. So I think what we have seen just over the last year or two, and what we'll see over the next couple of years, a tremendous amount of both private and public investments in actually treating people with these problems. And I'll just give you a couple of examples of that. So just about the same time that we got this tremendous gift to start the Garvey Institute, we also developed a wonderful partnership with our state here. This is a Seattle Times article from late 2018, where Jay Inslee, our governor, stood up and said, we're going to spend $700 million to try to address the mental health crisis in Washington State. And as the UW, we partnered with them on 3 big aspects of this. We said, we're going to help you train a whole bunch more people who can help people with mental health addiction problems, because we have a tremendous workforce shortage in this area. We said, people need help now. And there are a lot of doctors and psychologists and nurses and midwives out there who don't know what to do when they see a patient like this. We're going to set up a 24/7 consultation service with anybody, where anybody in the state taking care of a patient with these problems can call a psychiatrist here in our department 365 days a year, 24/7. And a whole bunch of you actually work on this consultation service, and it's been a super great, successful thing. And then finally, we said, we're going to take $250 million of the state's money and build a facility that really is the kind of setting that people want to see, that need to see to get good care. And we're going to show you a few examples of all of this. This is sort of my effort to try to put all of it on a slide, and I can't narrate all of it because it's just too much. But sort of the bottom line is, what I say to people now is, how do we as UW Medicine try to take on this problem? I start at the top left. If you are in a crisis, if you need help right away, what I would say is it's no different from, if you had a broken leg today, if you get in a bad car crunch, where do you want to be? You want to be at Harborview Medical Center. And the same is true if you're in a serious mental health crisis. I think Paul is here. Paul Borghesani runs our psychiatric emergency service at Harborview. And that's the only place in the county where you can see a psychiatrist 24/7. So if you're in that kind of a serious acute crisis, I would say we have a lot to offer there now. And we're going to try to strengthen this over the next couple of years with the Behavioral Health Institute there. If you need a place, well, it'll take a little bit longer for you to get well. You need longer care. People who are really struggling with really severe persistent disorders. That's what our new facility at the UW Medical Center Northwest Campus will do. And I'll say a little bit more about that in a minute. If you need advice right away, anywhere in the state, any of the providers can now call us and say, I want to talk to a psychiatrist about this really difficult patient that I'm trying to help. And Molly is here. She helps us organize that service. Rick and many of our colleagues are consulting on that service. So thank you for that. And then, the Garvey Institute, where does it fit in all of this? Well, we can do all this care, but we also all know we need better answers. We need new treatments. We need new solutions. We still have patients where, with all the stuff that we can do for them right now, we don't have an answer for them yet. And that's, I think, where we're investing with the Institute. And so I think there is a way that we can make it all come together over the next couple of years. So I'm going to have Ryan Kimmel, who is our Chief of Psychiatry at UW Medical Center, say a little bit about this new hospital we're building. Okay, sorry, I went to your first slide.
Thanks very much. As Jürgen said, I'm Ryan Kimmel. I'm the Chief of Psychiatry over both campuses of the UW Medical Center. And I'm going to talk about the behavioral health teaching facility that we're building. This is Western State Hospital, circa 1892. In an era where there were not very many effective treatments for serious mental illness. And to a large degree, we sent patients away. This is in Stillicum. The building is still there. The facility is still there. In the 1880s, the biggest cities in Washington were Seattle and Walla Walla. We did not build the large facilities like this in either of those cities. And if you think it's difficult to get to Stillicum, the south of Tacoma, with I-5 traffic, in the 1880s, you had to get there by horse or ferry. And so it's a long, we did not take care of these patients amongst us. And the facility was a standalone facility. It's not affiliated with a hospital to take care of the patient's medical needs, nor is it a training facility to a large degree. Our trainees, except for some of the child parts of this institution, don't train there. And so the idea, as Jürgen alluded to, became let's build a facility in a modern way and think about how the placement of the facility, the design of the facility can enable better treatments for patients with serious mental illness and better training opportunities and recruiting opportunities as we seek to encourage more medical students and nursing students and social work students, nurse practitioner students into the idea of coming to behavioral health. So this is a drawing that was done by probably some architect firm intern. They really went for photorealism with this one because it's raining and the sky is ominous and the person in the crosswalk has the ubiquitous Seattle waterproof parka. Wasn't quite the tone, but it was the best. So instead, yeah, it's true. The picture itself can cause seasonal affective disorder. So there's a webcam of the building being built. And so I grabbed a screenshot a couple of weeks ago on a sunny day. And so I'll point out a few things about, give you an idea of what's in this building. I'll talk about it in different ways and show you some other renderings. The building is on the campus of UW Medical Center Northwest, less than a mile from the new light rail stop on by Northgate. It's attached by two sky walkways to the rest of the hospital. It's important in lots of different ways that we don't think of psychiatry as something that's set aside either in the structure or what we do. The main floor will have the cafeteria for the whole campus. So at the hospital on Montlake, where we used to have a psychiatry unit, I was always surprised that lots of people work there had no idea where the psych unit was. Here they will, because if you want breakfast, you have to walk past the psych unit. There in the bottom left of that will be a neuromodulation center. There are lots of patients with serious mental illness for whom medication and psychotherapy is not enough, and who need ECT and TMS and other types of newly developed technological advances that can show significant benefit. We need to co-locate those in a way that makes it easy for us to develop new treatments and easier for patient access. And one of the Garvey professorship searches is for a leadership role in that neuromodulation center. There'll be 50 medicine beds in this psych building. So for patients who are suffering from significant medical and significant psychiatric issues at the same time, we should be treating those things alongside each other. Moreover, I have often found in hospitals that the staff who are good and like working with patients with serious mental illness only work on the psych unit and never move to the medicine floors. And when the patients themselves move, the doctors don't go along with them. So if I'm taking care of a patient on the psychiatry unit who has chest pain or whatever, needs to go to the medical floor, I can follow them. And so they don't have to be paranoid of the next person they see. The occupational therapist who's good and isn't intimidated by a patient who having hallucinations can see the patients on those floors. There are lots of ways to think about this in this piece of it. Other features of this I wanted to point out, there you can kind of see, and I'll show you a picture. There's an outdoor area on the 3rd floor. I did residency in San Diego where all the psychiatry units had outdoor areas. On my child psych rotation, I would play ping pong and shoot hoops outside with the adolescents. And yet, oftentimes in Seattle, for psychiatry units, they're kind of retrofitted into a medicine unit. They aren't designed with the outdoors in mind, either with what the patients can see or what the trainees can see. And so I'll come back to some of these things. And then also in this building, we'll house our psychiatry residency training program, as well as some other training programs. So this idea of hospitalizing the patients where they live is important. Family can come and visit them without a horse or a ferry. The patient's care managers and case managers from the clinic can come and visit them and can improve the transition out of the hospital. The person who runs an adult family home who might be able to give the patient a place to stay can come and meet them. And so it isn't such a stark jump between inpatient and outpatient care. And then the idea of co-locating longer term care with in an academic medical center has lots of advantages too. I mentioned the access to specialty medical care and psychiatric care because these things don't, if anything, serious mental illness and serious medical illness compound each other. And so it'd be useful to be able to co-locate these things. And I mentioned the ease of transitions for staff or for the patients themselves. If they don't have, it's an elevator ride away to the medicine floor and not an ambulance ride away. It's safer. The idea of being able to start from scratch with a facility design has been an extraordinary opportunity as we think about the training environment and then the healing environment for the patients. And then the workforce development, there's a lot of pieces to this. If we can capture trainees early on before they decided what they really want to do and give them a great training experience in a nice facility with people who want to teach and with evidence that patients are getting better, I think it would be huge for recruiting. And this is at all levels. The idea of learning together. So care in hospitals happens in teams. And so the social work students, the nursing students, the medical students should all be learning alongside each other because they're going to be working alongside each other. Currently in psychiatry, 50% of psychiatrists in the United States open up cash-only private practices. And I would like to give our psychiatry trainees and our psychology trainees a training environment that in itself is part of the recruitment to help take care of geriatric patients who will be in this, and as well as long-term patients with serious mental illness. Give them an idea that there is something there that can be is attractive and can compete against the market forces that make psychiatrists open up outpatient cash-only practices. Jürgen mentioned the legislative commitment. So I want to show you some of the pictures of what I was talking about, some of the renderings. This is a common area of the psych unit looking out to the outdoor area. You have to make these areas attractive. No one's depression gets better if they just hang out in their room, either at home or at the hospital. It's one of the paradoxes where on a medical unit, the care takes place in the patient room. On a psychiatry unit, the care takes place outside the patient room. And so you have to give patients reason to come out. And that includes attractive areas. This is the outdoor area. Some of this was inspired by what I saw to some degree when I went down to UCLA when we were interviewing an architecture firm way at the beginning of this. The idea of an outdoor area where you could get plenty of light with plantings. If you plant things in Seattle, there will be birds and hummingbirds, and there'll be nature as well that will come in there. But the idea that this is not a forensic institution where you are only inside, and it's not just this one outdoor area but every floor has a smaller outdoor area, kind of like a deck. Or if you think about these patients will be spending up to 6 months at this facility. You want to have spaces that kind of replicate a home. In your own house, you have a bedroom, you have a living room, you have some place where you can see the outdoors. And so we need to replicate that so that when they have those access to those things after hospitalization, it'll be useful. This is a painting of the room. Most of the rooms are single rooms. We don't build in medical hospitals. We don't build shared rooms anymore. And I feel strongly from an equity point of view, we should be matching this for psych hospitalization too. There are some shared rooms because some of these patients, when they leave, they're going to share a room in an adult family home. So maybe towards the end of their hospitalization, you might want to have a roommate for a while and learn how to make that go okay. But most of the time, there's a combination of private places where the patients can go and also more public areas. There's the lobby. 1 minute. This is I thought Becky might have to have like an old vaudeville cane to jerk people up. It's a public facility. We want it to be welcoming. The neuromodulation center is off there. It's not the facility design is not something that would scare off the public, nor the patients. So I wanted to show you some pictures and talk about how the design fits the mission. So, all right.
So Ryan, you gave us a little preview of what we're gonna have. The building is up. We got a year to put stuff inside that building, and then we got to hire 3 or 4 or 500 really talented people to help care for people. And there's a lot of people who deserve credit for building this. One of the things I said to Jay Inslee when they were having tremendous struggles at the state hospital about 4 or 5 years ago, he said, "Can you come down here and run it?" And I'm like, "I wouldn't touch it with a 10-foot pole. This thing is 200 years old." Right, not quite, but it's a scary place, and people are there and they're out of sight, out of mind. We need to have something much more modern in our community where people are living, and that didn't go very far. And then they had more trouble, and he called me and he said, "Jürgen, what I should do with the state hospital?" I said, "I don't know." I said, "You should have all the patients go on a field trip and drop a cluster bomb on it. You got to start over. You cannot keep driving." And I said, people who have cancer, they come to a beautiful, shiny new facility right here at South Lake Union that's made out of steel and glass, and it looks nice. And the trainees see that and they're like, "Oh, I could be a cancer doctor." People who see the facility down in, south of Tacoma, that's not going to make you want to sort of become a person who helps people with mental health and addiction problems. So it was a journey, and I think we're well along the journey. And sometime either late this year or early next year, we're going to open this facility, and I hope to see many of you there when we do. All right. I'm going to talk a little bit before Amanda comes up about when we have a new facility, we can do new things. We can do new treatments, and we need new treatments. And so one of the things, this is a goofy little slide, but this is a point about innovation in mental health and how do we fund it. This is a little article from The Guardian and another article from The Economist that has looked at how are we funding innovation in science and innovation in healthcare. And the article on the right from The Economist says people spend a lot of money, especially charitable giving and philanthropy, on things like cancer and heart disease, almost nothing on mental health. And that is something that we are making a huge change in, with the help of the new Garvey Institute. And as I said earlier, when you start making a clear case that this can make a difference, this might actually be a really smart place to put your money. Other people start paying attention to it. And I think we're seeing that even in a very, very short time. So let's see. Okay. So in this new hospital, we're going to have a clinic. Ryan pointed this out. It'll be at the bottom floor, and we're going to call it the Garvey Institute Neuromodulation Clinic. That will be able to offer a whole bunch of treatments that we currently don't really offer in our academic healthcare system. And I feel we're a little bit behind the times on it. And it's a good opportunity for us to catch up and even to advance some of these new treatments. And one of those new treatments are treatments that you could sort of summarize under the theme of neuromodulation treatments. So I'm going to say a little bit for those of you who are like, what the heck is that? So the idea of neuromodulation is not to give a medication, but to take a way to stimulate the brain to help modulate that complex neurocircuitry that we have, to help normalize, or if you wish, bridge a circuit that's not functioning properly. And how can you do that? You can use direct electrical stimulation. You can use strong magnetic fields or other approaches to try to do this brain stimulation. And these approaches have now been shown to help people with depression, severe depression. If you are a person who has schizophrenia or another form of psychosis and you get what we call catatonia, they can be helpful with that, and a number of other serious brain health disorders. They're real alternatives or additions to medication treatment. And we currently don't have a lot of that on offer. And with this new facility, we're going to be able to offer a whole range of new treatments like this: ECT, TMS, transcranial direct current stimulation, direct cranial nerve stimulation, and then partnering with our colleagues in neurosurgery, we could do some deep brain stimulation. All of these techniques have potential to try to help people with really serious mental health and addiction problems. So I'm very, very excited to have the opportunity to be able to bring those new treatments to our local area, our local market here. Another area that we're investing in, there's a whole bunch of other novel therapeutics. There's a whole bunch of excitement in the media now, and actually even in our state legislature, about sort of the both the promises, but also the perils of using substances that are called psychedelic substances. So these are either things that are naturally occurring. So psilocybin is something that's in a mushroom, or synthetic things that we lump currently in pharmacology under the category of psychedelic substances. Many of these things have been for many years considered just pure drugs of abuse. And it turns out if you use these molecules in the right way, in a smart way, they can be very helpful to treat things like depression or PTSD or anxiety or even addiction. And the challenge in this area, from my perspective, is there's a lot of heat and not much light. People are very excited about it. Everybody thinks it's either the next panacea or the next devil, and the truth is it's probably both. And so what we have to do is bring some light into this area, not just more heat. And that's the goal we're doing here. We developing a new center for novel therapeutics. Initially, we'll focus that mostly on addiction. And the idea there is, can we find really smart, sophisticated, safe way to use these kinds of compounds to help people who are struggling with addiction problems? And when we do that, we need a place to try to do that, to offer that, to test that. And that's going to be my transition to Amanda, who's going to talk a little bit with us when we have these kind of new treatments. How do we get them out there? How do we start using them with patients? So, and Amanda is going to tell us. Amanda is the medical director of our outpatient psychiatry clinic at Roosevelt, and she's going to tell us a little bit about the work she and her colleagues are doing there.
Hi, everyone. I'm Amanda Foch, and as Jürgen said, I'm the medical director of the outpatient clinic. And this clinic has been around for a long time. I think that Jürgen even practiced there a long time ago.
It first opened about 30 years ago. I was one of the first doctors there.
And so we do, work there day in, day out. I have colleagues here that I work alongside, and we're talking about sort of where we're going and what we're building on in the clinic. So just to give you a little bit of an overview of what we do. So we have, our mission is to care for generally complex patients within the UW system. And we have several specialized service areas at the clinic: perinatal psychiatry, psychology. You heard from Amrita Bhatt earlier, who leads that program; addictions, geriatric psychiatry, psychology, and a new emphasis and access to OCD specialization. We have social work services, and we also have nursing services at the clinic. These may seem like standard things that you would have in any clinic, but it's actually been, kind of a journey getting those services built out in the clinic so that we can better provide care for folks. And we are lucky to have 12 attending psychiatrists who work, varying amounts of FTE, 9 attending psychologists, 2 social workers and social work assistants. That has been built out in the last year. And we now have 30 rotating psychiatry residents, which we essentially doubled the size of the resident rotation in the past year, which has been really exciting. It's actually gone quite well for rotating psychology residents as well. So this is a very simple graph. It basically shows an upward trend in the number of visits. And if you'll note the dates that this trend is happening, it's 2020 to 2022, which is pretty much in the heart of the pandemic. And so we went from seeing, a little more than 2,000, or having a little more than 2,000 visits per year, upwards of over 4,000. And the reason for that is a whole combination of different things. It's through hiring, it's through being more efficient. It's obviously through expanding access through having more residents there too. And along with the increase in visits is our increase in referrals. So there's a tremendous need even within the UW system that we can't possibly meet. There are just so many patients that need care and treatment. And so we really are thinking, how can we expand access just across the board for just general psychiatric services, as well as more specialized services. So speaking of COVID-19, obviously very challenging to figure out how are we going to continue to see our patients. And there's a lot of scrambling at the beginning. We were lucky to have had a couple of pilot programs looking at delivering telehealth through the clinic. And so we were able to build on that. And we actually pivoted pretty quickly. We were able to maintain our visit volumes, within the first couple of weeks of rolling out telehealth. We ask our patients to choose if they want in-person care versus telehealth care. And 75% of our visits are telehealth. So patients are voting for this as a service. It's obviously, I think we all know, it's very convenient if you have a busy day to be able to log on, and especially something, with mental health where it's all talking. It's a technology that's quite suited for what we do. We've also been able to expand our geographic reach. It used to be just like a whole production. I had a patient who used to fly in from the Tri-Cities and then go back to someone who had kids and needed to get home to see her family just to see me for an appointment. We can now just see those folks much more straightforwardly. Reduces the number of no-shows. I think it's because it's easier. You're not stuck in traffic. And it's also because if someone hasn't shown up, we can just call them and be like, hey, where are you? And like, oh, I forgot. And they'll log on and we can see them. And it also increases efficiency. It's a very efficient technology because we're not getting up, walking to the waiting room, waiting for patients who are late. And we end up being able to see more patients in a given clinic session. So I mentioned all of the wonderful residents that we have at the clinic, and this is a little bit of a snapshot of what they do. So we welcome our 2 residents to come and see their first outpatients. And these are residents who have worked in the ER and seen very complex patients on the inpatient unit. But it turns out if you have to sit in a room or look at someone on screen, and talk for 45 minutes to an hour, it can be quite anxiety provoking. And we have just an excellent training program kind of easing residents into this. And then that just gets expanded for our residents who are in their 3rd year and they have their first patient panel. It's outpatients. They see new patients alongside an attending with direct supervision. So the attending is interacting with them around understanding those patients. Then they build out their panels, and we just have fabulous psychotherapy training delivered by my excellent colleagues at the clinic, and they learn and have access to supervision in a bunch of different modalities. And so the attendings also do run a weekly supervision group for the residents where they get to interact with an attending psychologist alongside, and also psychology trainees within those supervisions. The R4s continue their good work in the clinic, and then psychology residents also rotate through and work with our attending psychologists. So these are recent areas of growth that we've been doing over the last couple of years, and a lot of it has to do with hiring. As Ryan mentioned, it can be difficult to recruit, and we have a lot of recruitment to come with the new hospital and institute, and so we're always looking for folks. So we've been able to recruit psychologists. We've been able to expand our social work hiring, and those are all frontline clinicians delivering psychotherapeutic services. And we've also begun to innovate in providing more groups, which just allows us to treat more patients at the same time. We've built out in the last couple of years these embedded specialty services, addictions, perinatal, and then the geriatric and OCD. So future directions, we are excited to begin to pilot doing clinical trials at the site. So as you heard, all of the great innovations that people are doing, ultimately you need a patient population to see if that's going to work. And so we have a couple of things in development. We actually have a couple of pilots that we hope to get started soon, and areas that we're looking at right now are addictions, integrated care, the novel therapeutics that Jürgen mentioned, and also suicide prevention, all super important areas that we've heard a lot about today. We also are looking to expand treatment access and options through recruitment, continuing to recruit excellent folks. We have an exciting partnership that's coming up with the anesthesia department. So we're located in what's called the Roosevelt 1 building, which is, there are 2 Roosevelt buildings. One has a lot of primary care services. Ours is next door, and the anesthesia department has a built-out interventional suite upstairs, and it provides us the opportunity to consider offering ketamine treatment to patients, which we're very excited about. So we're working out that collaboration now, working to develop a mentalization-based treatment. So mentalization is a psychotherapy that shows a lot of promise. It has a great evidence base. It's practiced in the UK. We're looking to bring expertise into that treatment. It can be applied to a number of different patient populations. We're looking to expand treatment for patients in suicidal crisis. We're lucky to have Kate Comtois, so director of the CSPAR program, who practices in the clinic and does the DBT program there, who has a lot of ideas about how to adapt various different interventions to help patients in suicidal crisis. And we're continuing to build on the number of groups that we're offering so that we can hopefully keep patients from lingering on our wait lists who need psychotherapy and get them in and talking with a clinician and interacting with each other to provide care. So that is the overview. Let me know if there are any questions at all. Okay.
So let me say a big thank you to Amanda and to all of your colleagues. This is the real work every day with the patients. We could talk about all kinds of neat, new, shiny things, but at the end of the day, we have to help patients get those shiny things, and that's what you do. You run a beautiful clinic, and anybody who's doubling the number of visits in a place that's been running for 30 years and never have seen that many patients, hats off. So thank you for that. All right. I said earlier, and we heard a little bit in the innovations grant, also important for us to think about what can we do, not just for the patients, but for the family members of the patients that we see or that we don't see. And I'm going to ask Molly Forrester to talk a little bit about some of those efforts that we're making, because I think there is a huge amount of opportunity. And most of us in our training, in my training, and we now have here, I wanted to say one more thing, sorry. We have the largest psychiatry training program in the United States here at UW Medicine now. And it's in part because of the kinds of things that we can offer our trainees. They have tremendous opportunity to learn some things. One of the things I did not learn is how to help and talk to family members. I learned how to talk to patients, and then the family members would come and say to me, "That's nice that you're doing all this stuff with them. What should I do when you bring them home?" And I'm like, "I don't know." And I think that's a little goofy, but it's a real thing, and it's a real challenge, and it's a real opportunity. And Molly is helping us think about that. So there you go.
Good morning, everyone. How do I do this? Okay, thank you. Not the most technologically savvy, so I apologize in advance. So hello, everyone. So I'm Molly Forrester, and I am here to talk to you today about patient and family support programs that exist within our department. A little about me is I'm a clinical social worker by background. I trained on inpatient psychiatry at Harborview, so coming to the department has been a little bit of a homecoming and rejoining with some folks I trained with up on the inpatient units. I've been a social worker for over 25 years, and the majority of my experience was at Harborview. I've worked on inpatient psychiatry and psych emergency services. I did a stint in outpatient mental health at Purdy as an intern, and I also managed a couple of residential group homes. In that time, I had the opportunity to partner with lots of patients and families, and it's really been my privilege to do this work. I've seen remarkable journeys of recovery, but I've also witnessed those journeys really come across with a lot of hurdles for folks. And so to join with patients and families and those of us who strive to support the patients and their families and care for them is really a great opportunity for me. So though I've been in UW Medicine for over 20 years, it was just about 4 years ago that I had the opportunity to first meet Dr. Unitzer and learned about some of the innovative programs he was starting in the department, including behavioral health navigation and support assistance for patients and families, really focusing on how do we help people access really effective treatments. And I was struck by his sincere intent to make a difference, to really have an impact and use our collective learning to support and make lasting improvements to our behavioral health system. No small goal, but really important. And it really spoke to my history in the field. I know firsthand, I think many of us do, that navigation services are not something that's covered. It's really hard to pay for these programs and pay for these essential services. And so thanks once again to the generosity of the Garvey family. a new position was started in the department, and I am really honored to serve in the role of Director of Patient and Family Experience based out of our department. Since I joined the department in June of 2019, the Garvey gift has allowed us to serve thousands in Washington as we've launched several innovative programming. And I'm here today to talk to you about some of our program successes. So one of the things I do, what does a patient and family experience director do? So some of what I do is good old fashioned social work. I am based in the department. And so what that allows me to do is receive referrals directly from my faculty and staff colleagues. So I'm not attached to any one clinical site like I used to be, which really gives me a nice lens to our entire system and how it's working or not working for our patients and families. My goal is to come alongside families, come alongside patients, hear their stories, and provide them with custom and curated behavioral health navigation access assistance. I try to help them clarify goals, understand their unique experiences, and really strive to be a hub of information on a variety of diagnoses, levels of care, the related treatment options that might exist. You know, having a family member or a loved one with a mental illness is a confusing and overwhelming process for lots of folks. And I really just strive to be a calm in that storm and a centering voice and help people get pointed where they need to go. What I was also really struck by coming back to the work after more than a decade was there really is so much to be hopeful about. And it's really such a privilege to be able to share the information, the breadth of knowledge I get from all of you with the patients and families we serve. So a recent example, you know, just of kind of what I do, I recently was referred a young adult who was moving to Seattle from out of state. This person had a long and complicated course of bipolar illness. The parents were naturally very concerned. They were used to being at the hub of this child's recovery, the hub of this child's ongoing stability. And they really had played this central role, but now their child was an adult and the dynamic had dramatically shifted, as you might imagine. They weren't always on the same page. There were some conflicts going on, a lot of stress, attention, and a lot of fear. So I worked with the family. I directly worked with this young adult, really got a sense of their preferences, their goals, what was it that they were looking for, supported them in learning about insurance and how to advocate for themselves, how to find the right fit and providers they were looking for, both a prescriber and a therapist. Meanwhile, then I could partner with the parents, help understand like what were they dealing with? You know, this is real, right? We know the transition from the child to adult system can be really dramatic for folks. And so it was really, again, helping them find resources. There's some wonderful clinicians whose sole purpose is to help parents understand how to support their children, how to transition from being a caregiver to going back to being a parent and letting their child work with professionals and release some of that responsibility. Yeah, so sorry, back my notes here. One of the things that other things that I do in the department is I manage several consultation programs in collaboration with Dr. Kimmel. Many of these are made possible through a variety of funding sources. We both employer contracts, state and legislative funding, and additional donor funding has allowed us to really expand our team of mental health navigators. So if any of you are listening, I'm really grateful for all of you. This has allowed us to really increase our footprint and expand the number of patients and families that we serve. Together, we're constantly reviewing like the themes that we're hearing from patients and families. We're looking for identifying gaps in care and ways that we can respond more quickly and efficiently to the care needs people are seeking. We have an opportunity to provide direct feedback to Dr. Unitzer. Hey, we're really struggling with insurance parity and insurance panels, and hopefully advocate for systems to change at a bigger level. We've also taken the opportunity to really try and, oops, I'm ahead of myself, sorry, leverage technology and meet our patients really where they are, and a lot of the technology that we're hearing about today that allows us to reach more and more people. So sorry, now you've already had a preview. These are some of the programs that we run. So one example is Mental Health Care Connect. This is an employer-funded program where employees of this company can call us and get direct access to a psychiatrist and a mental health navigator, really putting the psychiatrist visit at the front end. This allows folks to get expert advice from the outset and then attach to one of our skilled mental health navigators who can help put the psychiatrist treatment plan into place, find those resources for folks that they're seeking. We have found that this allows folks to connect to care much more quickly and really get started on the course to treatment. Sometimes, a process that can often take people months can be reduced to weeks or even days. Then in July of 2019, we had the opportunity to launch the statewide psychiatry consultation line, a legislatively funded program. This provides provider-to-provider consultation, mental health and substance use disorder consultation to providers for free. Anyone in the state can call us 24/7 and almost on demand reach one of our psychiatrist colleagues. This is really similar to a program at Children's some of you may know about called PAL, the Partnership Access Line. And Dr. Bott is one of the faculty on our perinatal perinatal psychiatry consultation line. All of these programs aim to address the, what we've talked about today, the shortage of providers that exist around our state. I am very relieved to report that a recently completed legislative audit, a 2-year audit of the PCL, found that we are not only increasing access to care, but we have really high rates of provider satisfaction in the community, which is something we're very proud of. Another clinic that's been made possible was this perinatal telepsychiatry clinic. This is an offshoot of the perinatal consultation line. And it's donor funded. It's a program that is actually providing direct patient care through our perinatal psychiatry experts, including a perinatal addiction psychiatry expert. They are able to leverage telepsychiatry technology to reach patients throughout the state. This has been a really wonderful collaboration with our colleagues at Amanda's clinic at the OPC. And my mental health navigation team coordinates this virtual clinic, and to date have triaged hundreds of referrals, and this program just launched in spring of 2018. Oh my God, do I really only have a minute? Okay. In response to the pandemic, we also launched a couple of COVID response programs to support our workforce colleagues. One of the first things Dr. Onitzer said to me as the pandemic struck was mental health pandemic will be next. And so we had the opportunity to work with many of our colleagues. Some of them initially volunteered their time to offer informal support and provide supportive conversations to their colleagues. And then when our community rallied and gave us some money to stand up a more substantial program again with Dr. Focht in the outpatient psych clinic, we were able to provide direct access to care, and again, some curated mental health care assistance for folks who really needed it. In part, we use those donor funds to help support some of the social work positions that continue to support this work in OPC today. As we look to the future, what I am really looking forward to is what we've talked about today with all of the technology, the expansion at the new teaching facility and at OPC. I'm hoping that we will take advantage of opportunities to further engage our patients and families in developing educational curriculum for our own trainees and interdisciplinary trainees. We're really well positioned in our state and in our region to support such educational offerings that have the potential for real and broad impact. I hope to develop in-person and virtual resources that we could share statewide that are well informed by those with lived experience, including our patients and families. And I hope we can also expand those services into the community. Research tells us that information sharing like this can really help community members not only better understand mental health and addiction, but can increase empathy, increase support for our patients and their loved ones, and hopefully aid in prevention. The partners I think about, you've heard from today. I think about our Spirit Lab. I think about our Memory Hub over at the Memory and Brain Wellness Clinic run by Dr. Grabowski. And of course, really traditional partners such as NAMI. So in closing, I just want to say how grateful I am for the part my team and I have had the opportunity to play in the patient and family support work based out of our department. I am just personally and professionally so invigorated by this work that lies ahead for us, and look forward to working with all of you together to make this happen. Thank you.
Thank you, Molly. Molly has been a godsend for me, and so I'm often the person who gets the desperate phone call from somebody saying, help me. And there's just one of me. And I'm like, there needs to be at least one more of me. So Molly has been a wonderful partner for me, and also a wonderful partner for all of us, and will be a wonderful partner for all of us as we think, if we keep in mind, not just is the science exciting, are we going to do something really cool? But what about the people who are the beneficiaries of all of this? Can we keep their voice in mind? Can we keep in mind what they need? We could get pretty excited about all this cool science, but we still need to remember it's patients and families that need to somehow benefit. And how do we best do that? And that's actually something, Lynn, that you and I talked about before there was a Garvey Institute. You said, what about the families? What are you doing for the families? And I sort of thought about that and I said, yeah, we really need to think about that. So thank you. So we're actually amazingly on time. And so we're gonna take a 10-minute break, but don't go away for too long because we have a couple more really cool little presentations and then we're gonna all get out there and have lunch together. But take a little break and we're going to start right back at 11 o'clock. All right, so we're all social creatures and I made a mistake because I let everybody out and now I'm not going to be able to get anybody back in here, but thank you all for coming back in. And we're going to go back out there in about 50 minutes and then we can mingle some more. All right. Okay. I'm gonna wait another minute and I'll get us started again. All right. So we really need three things to make a difference in this area. One of them is we do need better solutions. We need better facilities and programs, but we also need more people. So that's what I'm going to focus on in this last piece. We need more people to work in this area, and we need people who could work in this area realize how exciting it can be. What a huge difference you can make in people's lives if you devote yourself to working in this area. There is a few of us who've been doing this for a long time, and we know that. But there is an enormous workforce shortage in behavioral health, mental health, brain health, and it's never been the most attractive place for anybody who wants to be in healthcare to go. It's traditionally been under-resourced, underpaid. Much of the stigma that our patients live with spills over to those of us who are providers, who are helpers, who are family members, who are caregivers, and that's also a challenge, and I think that's gotten better, but it still is a challenge. So one of the things that we have done is we have a whole bunch of really great training programs in the department. We have a great psychology internship programs that brings us really talented, really smart people into our department. And sometimes we get lucky and we get to keep them as faculty. And many of them are here today. I'm just looking around. We have a really big psychiatry training program, but we aren't going to solve this problem with a small number of psychiatrists and psychologists. So my fantasy about how we solve the behavioral health workforce problem is everybody should be a behavioral health worker. The person living with the illness needs to know as much as possible about what is this? How do I live with this? How do I get my needs met? The person who is a family member who's caring for them needs to know as much as possible about what is this? And then we do need to, think about who are others, professionals that can help with this. So I'm just going to call out a few examples of what we're doing to try to grow this workforce, and not just to grow it, but also to strengthen it, to make it more effective. Just over the last couple of years, we've talked the state of Washington out of a lot of things. I hope I'm not being taped in a bad way, but one of them is we said you do need more psychiatrists, and we got some money from the legislature, and we now do have the largest psychiatry training program in the United States, which is very, very exciting. And Amanda talked about 30 of them rotating in our clinic at any given time. That's tremendous. We're also fortunate. We are building a brand new nurse practitioner fellowship program in psychiatry. This is something we're doing in partnership with our School of Nursing. We got a small philanthropic gift to help us get started with the concept. And then last year, we got, in partnership with the School of Nursing, $6 million from Premera, which is a big insurance company here, to really help get this off the ground and run it for the first 5 years. We have, I think, already one of the leading psychology training programs here. Actually, we have 2 internship programs. One of them is at our Seattle VA, and one of them is in our department. And we're doing something else that I think is really smart. And I think I probably said something that upset some of our psychologists earlier about the math skills. So I'm going to just take a minute to work my way out of that. So one of the things that occurred to me, and I've had 3 children who've gone as undergraduate students to the University of Washington. Actually, every single person in my family is a Husky grad. It was a Husky, but what I hear when I look at our undergraduate programs now, what I'm hearing is some version of, the kids who come here who are in a STEM degree, who are becoming computer scientists and engineers. They're the ones who are going to get the really great, well-paying jobs. And all the other kids who are in the humanities, who are in the social sciences, who are in things that are not drawing so heavily on your math skills, you might come out and maybe you'll work as a barista, or you'll work in something else and you'll be paid like a barista. And it's a big difference. And I think it's really discouraging there are kids, and I have 3 of them, and so they vary. And one of them's got a serious math brain, and the other one, it's got a real person brain, and they're not always the same thing. Sometimes they're the same thing, but I feel like for this kind of work, we all need some math, but for this kind of work, you got to have really good human skills. You got to be a person. You got to know how to have empathy. You got to know how to connect with people. And there are a lot of people we have in our undergraduate programs who have those skills, and I don't think we take full advantage of it. So one of the number 1 majors in our 4-year program here, and this is true in all 4-year universities across the state, is psychology. But if you look at what they're learning, they're taking really cool, interesting classes in developmental psychology and experimental psychology and things like that, but they're not really learning how to talk to somebody. They're learning research skills, and some of them go on to do graduate training in psychology, but they're not really learning actual skills. So I took note of a program they built in the UK called the IAPS, the Improving Access to Psychological Therapies. And what they're doing there is they're taking folks during their undergraduate years and teaching them very concrete psychotherapy skills. How do you talk to a patient? How do you help them? How do you do cognitive therapy? And it turns out we have people in the department that have been able to teach those skills to high school graduates in the Democratic Republic of Congo to help patients. And I'm thinking, if somebody can do that, with a high school degree, why do we have to wait till they have a PhD until they get to do psychotherapy? So one of the things we're standing up is a program that will teach undergraduate students who have an interest in this, alongside whatever else they're learning, the skill of doing really good psychotherapy. And I'm super excited about that because there's a tremendous potential workforce there. We actually have a bill pending. There's a bill pending in the legislation this year to develop a new professional called the Behavioral Health Support Specialist. These are people who would be trained during their undergraduate years in providing evidence-based psychotherapy. And cross my fingers, and I'm not supposed to lobby, but I'm crossing my fingers that will move forward, because I think it could give us a real shot in the arm in terms of creating a workforce of people who want to do this work, who have the skills to do this work, and then might go on to do other training and other degrees. So anyway, I apologize for my comment about the psychologists and the math. There's some super smart math people in psychology. So now that I've worked my way out of that, I'll go on. One of the other things we need is we need more people who are doing mental health and brain health research who are also clinicians. I think one of the things I've seen, I came here as a fellow about 30 years ago, and I had a mentor who was a fabulous clinician, also a really, really good researcher. And every time we saw a patient, he would say, ha, and he would formulate whatever we were seeing as a research question. And it turned me on to become a researcher. And I just spent 20 years of my career doing really interesting research, but I'm still a clinician. And I think there is not enough of that anymore. We're now sort of seeing a lot of people who are either getting very good at the research stuff, or they're very good at the clinical stuff. It's very hard to do both. And I feel like we need to make a pretty serious investment in the concept of training clinicians as researchers and scientists. This is just a little graph. This is a graph of the age of people who are clinicians who have funding for research from the National Institute on Health. And you can see there's more people that have National Institute on Health funding who are clinicians who are in their 60s and 70s than who are in their 40s and 50s. There's almost nobody in their 30s and 40s. So we have a huge problem coming our way in terms of the pipeline of people who can be clinician researchers. And there are a lot of reasons for that. There's competing priorities. It didn't always used to be the case, but now our psychiatry graduates, they can come out and they get 4 or 5 job offers. They get paid pretty well. They could just go downtown, hang up a shingle and do cash only private practice. But that doesn't help a lot of people, right? We have, in many ways, research training is tough. Some of you are very smart, very well-trained researchers. And even for you, 1 out of 10 grants that we apply for to the federal government gets funded. That's a tough game to be playing in. So you need a lot of skills, you need a lot of support, and you need some time to do that. So we're going to start this year in our department a new program called the Clinician Scientist Training Program. We will have, we're about to announce, can't do it today, but we're about to announce a senior faculty member who will be the faculty champion to lead this project, and it'll be one of the endowed faculty positions that came with the big Garvey Institute gift. We will have a co-director for the program. We'll have some support staff. And we're going to do 3 things with this program. The first one is we're going to have an internal pilot grant funding mechanism where a trainee, a psychology trainee, a psychiatry trainee, potentially a medical student can get a 1-year grant to do a small research project. We'll do 2 funding cycles a year, just like what we've done for the big innovation grants that you all are working on. And these little grants are going to support the trainee and a faculty mentor. They're going to provide some support for the trainee to do the research. And it might be as simple as I need to go to a conference and present a meeting and present a research finding. That's fine. That's a small project. It could be done. It could be something much bigger. And we'll also find some funding for the actual time that the faculty mentor puts in to help. And the third thing we're going to do is we're going to set up in the department a little clinical trial consultation service. And I'll say a little bit more about that. We're going to also provide some, and again, on a competitive basis, early career startup support for promising junior faculty. These are people who finished psychology or psychiatry training, who are coming onto our faculty, who are needing to see a lot of patients to generate their salary, but we're going to give them 2 years, potentially 3 years of early career funding where we're going to protect some of their time so they can actually do some research. It's not the sort of scope of what some of you refer to as a K award. It can't be that scope, but it'll be something that would help somebody write a K award if they were successful. And finally, we're going to set up a little program that will help people with things like IRB applications. How do you develop a partnership? How do you do data safety and monitoring? All of the stuff that goes into clinical research that maybe your mentor can tell you about, but sometimes your mentor even can't tell you about, and you need a little help with that. So we're going to set up a little infrastructure of people who have those skills who can help with those things. So that's something we're going to get off the ground, and hopefully by the time we come back here next year, we'll have a whole bunch of little projects funded to really help that next generation of clinician scientists get some traction. All right, now I'm going to shift gears a little bit. We have one program that's no longer an idea, that's already up and running, and that is we have a brand new behavioral neurology and neuropsychiatry fellowship training program, something I had hoped to do. That's supported by the Garvey Institute, and Michael Schrift, who's one of our faculty colleagues, is going to direct that program and present about it. Michael, are you here? There you go. Come on down. Tell us about your new fellowship program.
Well, thanks for this opportunity to present this program. We're excited about this. We just got accreditation for this program, and I'm doing this in collaboration with my fellow faculty members. Dr. Personier I'm not sure he's here, but and Dr. Grabowski and other faculty that have helped develop this program. And so just a little bit about what behavioral neurology and neuropsychiatry is. It's a medical subspecialty that's committed to the understanding of the links between neuroscience and behavior. and the care of individuals who fall between the cracks of neurology and psychiatry. And this is a population that needs more clinicians to be able to take care of these very complex disorders. So training in behavioral neurology and neuropsychiatry entails the acquisition of knowledge regarding the clinical and the pathological aspects of and associated processes involved in cognition, emotion, behavior, and elementary neurological functioning. Expertise and clinical competence in this subspecialty requires a combination of knowledge and skills beyond the scope of those for general neurology or for general psychiatry. It's an integration of those two specialties. This knowledge and clinical skills is the foundation for the evaluation of patients with these very complex neurological and psychiatric disorders to understand the differential diagnosis. For example, if someone has hallucinations, you would expect a physician to be able to come up with a differential diagnosis of all the medical, neurological, and psychiatric disorders that can cause hallucinations. But unfortunately, that often doesn't occur. This fellowship would direct physicians to be able to understand those relationships and be able to do that differential diagnosis. The cornerstone of any treatment plan is the diagnosis, the accurate diagnosis of a patient, and then coming up with what the prognosis for that illness is. And that's something that would be involved in the training in this fellowship. Understanding pharmacologic interventions, neuromodulatory interventions that were talked about earlier today, psychosocial management, and the rehabilitation of these individuals who are suffering from these very complex neurological and psychiatric disorders. The body of knowledge and clinical skills involved in this are additive to neurology and psychiatry and integrative between those two specialties. So there needs to be specialized training that is directed to train physicians to understand these very complex disorders between the borderland between neurology and psychiatry. And if you become board certified in this, you can call yourself a behavioral neurologist if you came from a neurology residency, or you can call yourself a neuropsychiatrist if you came from a psychiatry residency. I'll talk a little bit about the disorders that people who subspecialize in this area treat. And part of the training will be to see these kinds of patients in a supervised setting. So it includes illnesses like Alzheimer's disease, frontal temporal dementia, Lewy body disease, vascular cognitive impairment, Huntington's disease. There's a whole literature and a whole bunch of patients suffer who have psychiatric complications of epilepsy, and psychiatric illnesses in themselves put you at risk for having a seizure. So it's important that doctors know about how to treat these patients and how to diagnose these patients. Traumatic brain injury is probably the #1 cause of neuropsychiatric illness in the world. And physicians need to understand TBI and be able to know the differential diagnosis of the psychiatric and neurological problems that occur in TBI and how to treat them. The neuropsychiatric aspects of movement disorders like Parkinson's disease, neuroinflammatory disorders. We're learning a lot about how the immune system could attack your own brain and cause various causes of psychiatric illnesses, like a schizophrenia-like illness, catatonia, depression, anxiety disorders. So people with multiple sclerosis, people with lupus, people with autoimmune encephalitides, they all often present to psychiatrists with various psychopathologies. Toxic, metabolic, genetic disorders that could cause changes in behavior and changes in cognition. And lastly, part of the training will be in neuroimaging to understand the various neuroimaging technologies and be able to apply that in clinical practice. I talked about a lot of things in a few minutes here, but I want to thank you. And I also want to thank the Garvey family for helping to support this, and also the 2 departments of neurology and psychiatry to help support this, I think, needed fellowship. Thank you.
thank you, Michael, for helping us stand up this great program. I'm just going to go back to one of your slides here because I got to tell you, I'm a psychiatrist. I've been doing this for a long time. I think I'm pretty smart, but you give me people who are living at this with these challenging disorders at the borderland between neurology and psychiatry, and I'm just very happy that we have a few really talented people like you in the department. But we need a lot more people who can work at this interface. You know, our traditional, buckets in neurology and psychiatry don't do us a good service when we have patients who are struggling with these things. And so I think helping neurologists appreciate the psychiatric aspects of what they're seeing and helping those of us who went the psychiatry route understand what's going on in the brain and working with a smart neurologist is the best way I can think of to help us take that next step, to help our patients who have these challenging problems, who when they're not getting better, because it's something I've been taught to do, I can't just throw another thing that's the same thing at them. I should be taking a step back and saying, what's really going on? You know, what's going on in the brain? And it might lead to a very, very different treatment. And I think it will take people that you're training in this program with that kind of skill to help us when we're getting in trouble with these really, really challenging problems. So thank you for starting that. Okay, now I'm going to call up Tom. Tom is relatively recent, been selected by as part of a national search as the first holder of one of the endowed professorships that is part of the Garvey Institute. Tom is a neurologist. He's a neuroimager. He's a really smart guy who has been with us. And I am very happy to be engaging Tom and all of the good work he does with patients and families in cognitive aging as part of the Garvey Institute. So come tell us a little bit about how we all can learn more about cognitive aging and how to keep our brains healthy.
Thank you, Jürgen, for a generous introduction. And I just want to take a second and commend you on the leadership of the Institute in the interdisciplinary spirit in which you've sort of engaged a number of sectors of the institution in this project. I think the interdisciplinary collaboration and innovation at the UW is one of the strongest features of the institution. And I'm here as a representative of that sort of spirit. So thank you so much. Also, in the same spirit, I want to start out with a 101 here. This is a cognitive aging 101, 2 slides, no more. First of all, adult cognitive development is a thing. We continue to develop our cognitive abilities well into our 30s and 40s. This is work that's been done, spearheaded by a really eminent scientist that's been in the psychiatry department here, Warna Shaya. And successful cognitive aging, although it involves some tailing off of abilities, really doesn't involve serious cognitive loss. But the issue is that preclinical degenerative disease is quite common. We've now learned that using techniques like specialized brain scans or measuring proteins in spinal fluid or in the near future in the blood, that you can detect degenerative changes 15 years before people have any symptoms. And in that period, it's really not possible to separate successful cognitive aging from pathologic aging without some sort of biomarker test like that. And if you ask how many people would have evidence of Alzheimer's disease at age 70, it's about 20% or so by these biomarkers. So it's a big problem. And the interesting thing is that some brains are more resilient to this disease than others. And this is an interaction between how your brain develops and how you take care of it over the years and the preclinical disease that's happening in many of us. And it all comes to a tipping point. And one's individual tipping point is strongly influenced, not just by genetics, but also by what your lifestyle is. Your education, your level of occupational challenge, your cognitive habits week to week, integrated over those decades through midlife. And also health factors like the quality of your sleep, how well controlled your hypertension is, your mental health, and regular exercise. All of these things can make easily a decade or more difference in when your tipping point would happen. And as you can see, many of these things are modifiable. So we think there's an important component of prevention possible. And just for reference, the strongest genetic risk factor we know about makes about 12 years difference in your tipping point. So these lifestyle and health factors are almost equally important to some of the genetic factors. So that gets us, to wonder what's the biology behind these factors and how can we and our trainees improve the brain health of the public. So I've been asked to talk a little bit about how the educational opportunities that are afforded by the Garvey Institute weave into and strengthen the opportunities that we already have at the University of Washington. And we're talking primarily today about training clinicians and in terms of postgraduate sort of clinical training, that is residents and fellows. The existing programs, some of the existing programs are listed here at the top. There are existing geriatric psychiatry fellowship and geriatric medicine fellowship programs and strong fellowship programs at the VA Puget Sound. Our Memory and Brain Wellness Center Clinic at Harborview, which we've been working on for the last 8 or 9 years, is a prime venue for some of the training in this area now. We have a busy clinic with around 4,000 visits a year, 1,000 new patients a year, and we already have rotating neurology, psychiatry, I should say, geriatric medicine fellows and social work students in the clinic. The new behavioral neurology and neuropsychiatry fellowship program that Michael just told you about will have 1 neurologist and 1 psychiatrist annually participating in the program. So we have a mix there where the specialties are interacting sort of organically and on a very solid base of training material. So we're very excited about the Garvey's support for this new program. For research training in this area, again, there are some existing programs like there's an NIH-funded so-called T32 mechanism, Alzheimer's disease training program that's been around for a number of years, led by Elaine Peskind and Brian Kramer, which provides major federal support for pre and postdoctoral trainees. We expect and hope that this will interact very positively with the new behavioral neurology and neuropsychiatry training program. This is a win-win situation because it can afford a research year for the clinicians in training, and it can bring more MD trainees into the workforce, which is something the NIA is interested in, and also therefore the T32 leaders. There's another NIH-funded so-called R25 training program that supports clinical neuroscience trainees, that would be neurosurgery, neuroradiology and neurology residents and fellows. That's another resource we have, and the existing MIREC, that's the VA Puget Sound, and MD PhD programs at the UW. And then training doesn't stop with that. As Jürgen was talking about, our junior faculty who would like to introduce a research component into their work need support. And we have designed the research education component in our Alzheimer's Disease Research Center to enhance the resources that are available to postdoctoral trainees under the, or to junior faculty trainees through, postdoctoral and junior faculty trainees, including scholarships for Big Data Summer Institute and close integration with ADRC-funded pilot projects, sort of broadening the panel of mentorship that's available to junior faculty at the UW. And then I introduced Brain Health 101 at the beginning to talk about resilience to Alzheimer's disease and how we are proposing to make this a much stronger focus in our Alzheimer's Disease Research Center in the next 5-year funded cycle, and catalyzed by the ADRC and the Garvey Institute. We're instituting a new scientific interest group or working group that's modeled on very successful groups that we have utilized to study tau biology and neurogenetics. Those existing groups have been spearheaded by Dr. Tom Bird, an eminent neurologist and neurogeneticist at the University of Washington. And we're very fortunate that Dr. Eric Larson, who is an internationally renowned worker in the area of brain health and resilience, is interested in participating in this group as an encore project as he's just recently retired from his role as PI of the ACT project. So we're excited about this as a timely and scientifically interesting focus where we can have a realistic chance of preventing Alzheimer's disease dementia. And finally, for primary care providers who are going to be seeing the lion's share of people with memory disorders, we have Project Echo Dementia. A little while ago, Michelle told you about an Echo pilot project. This is the same sort of Echo model that's state funded and targeted at primary care providers across Washington state. We currently reach many dozens of providers with a bi-weekly all teach, all learn collaborative learning session done by telehealth from the Memory Hub, which is a adjunct to our Memory and Brain Wellness Center. And then we interact with a primary care continuing medical education workshop program spearheaded by Dr. Barack Gaster, who has developed a really at this point internationally recognized program that interacts also with Echo Dementia and our ADRC. So those are some of the opportunities that we have for training around cognitive aging at the UW, and all benefiting from the Garvey Institute in several ways. By outright new training programs like the Behavioral Neurology and Neuropsychiatry program, by potentiating our existing programs, by funding these innovation awards to the junior faculty that we will be mentoring, and by promoting a thematic focus on mechanisms of pathological aging and brain resilience that can affect the scientific direction of us as an institution. So thank you very much.
Thank you, Tom. So I think what you just heard rounds out beautifully. We need good, healthy brains from even before we're born all the way to when we're in our 80s and 90s and even beyond, right? And how do we keep our brains healthy? This whole concept of resilience, I think, is fascinating. It's getting a lot of traction. I was fortunate enough, I trained at UCLA. At that time, we actually did have a really strong group of doing behavioral neurology, neuropsychiatry, and we learned a lot about tracking the brains as they were breaking down, but we weren't thinking all that much about what keeps them healthy, because they're not all breaking down. Because in the clinic, all we saw is the people who would come in and saying, my brain's breaking down, it's not working. And I think now we're really thinking very seriously about, how do you keep it healthy? How do you make it more resilient? What is that all about? What's the biology behind it? And then how can we turn that into interventions? So I think also a very, very important area to invest in. And thanks to you and your leadership for doing that. Okay, I think this is is that right, Becky? You're last, so you can be the best. No. So, you heard a lot about ways we're trying to chase down better ways of helping people. You heard something about programs we're building, facilities we're building to try to help people. And you heard a little bit about what do we do to try to help more people get into this business and get good at this business and be very successful at doing this work. And so that brings us to a challenge that we will all have over the next couple of years. With all these great opportunities that we've created, we're going to have to do a lot of really good recruitment. And I'm going to need everyone's help in this room to do that. And Becky's going to talk a little bit about recruiting and that.
Okay, so I'm Becky Sladek. I'm the Administrative Director of the Garvey Institute. And as Jürgen said, I am the last presentation for the day. I am the only thing keeping you from lunch. So I will be quick, and I have a few cartoons to get us to the finish line. So we've sat, this morning and heard about all of these really great programs that either already exist or that we're about to launch. And all of these programs need people. People are our biggest strength. People are our biggest resource. You can have the best ideas in the world, and if you don't have the people to move that idea forward or to do the work, it doesn't really mean very much. The UW Medicine leadership has told us that we need to hire about 300 to 500 professionals to staff the new behavioral health teaching facility that you heard about from Dr. Kimmel. That's everything from nurses to cafeteria workers and lab technicians to janitorial staff. It takes a lot of people to start a new hospital, and we're basically starting from scratch. So we're already partnering with the hospital and working on a recruitment timeline to get these people into place because it's such a big lift. Mind you that all these people need to be hired and trained before the first patient goes through that door. And that's when we start getting clinical revenue. So we are going to be looking for startup support as we launch this brand new fantastic hospital. We also need mental health professionals at the new behavioral health teaching facility. And so we need psychiatrists and psychologists and psychiatric nurse practitioners. Okay, good. The cartoons are helping. And as we all know, there's not enough mental health professionals in Washington or in the nation. So this is going to be a challenge for us. We know that the facility is going to be fantastic. It's going to be an attractive place for people to work, but it's still going to be a lot of work to get people hired. So we are creating a new position on our department human resources team, specifically to help with recruitment over the next few years. That's in process. We're going to be going to regional and national conferences and staffing recruitment booths. So if anyone has any ideas about where we should be going or who we should be talking to, please let me know. We're also, doing innovative, standing up innovative programs to develop the workforce, as Dr. Nitzer mentioned. For example, the Psychiatry Fellowship for Advanced Nurse Practitioners. Again, this is in partnership with the School of Nursing, funded by philanthropy and a new grant from Primera. It's going to allow up to 4 advanced nurse practitioners to have a 1-year fellowship in psychiatry so that they can better support and care for patients with mental health. Some of the training will take place at the behavioral health teaching facility, and we hope it's a pipeline so that we can then hire those fellows to either work at the new facility or elsewhere in the system or somewhere else in the state where they're badly needed. We also have a really great tool in the endowed professorships that the Garvey Institute supports. I think you've heard about all 3 of these open recruitments. We have several other ones. I just want to point out that these are really good tools for us in terms of recruitment and retention. So we can do external searches to bring in expertise, but we can also use them to elevate and support the expertise that we already have. So they're really, really important for us in building the workforce that we need. Also, there's some really nice synergy going on. So we've got this brand new facility, which is allowing us to build brand new programs, which is allowing us to bring in new people and new expertise, which is allowing us to then staff that facility. So there's some really nice, it's just a really exciting time for us. Lots of good opportunities and possibilities. Okay, so then this is the big takeaway message. Everybody in here knows somebody and they know somebody. So we need help in recruiting the best and the brightest. I think President Kelsey called it the top talent. So I've got a neighbor who's a nurse at the VA and wants to work at the facility. So I chat him up whenever I can and give him updates, right? So use your networks, help us bring good people in. That's the ask for my talk. And the best way to stay in touch or to learn about at least the Garvey funded opportunities is to be on our newsletter listserv. I'm pretty sure everyone in this room is on that, but if not, you can sign up on the website because we do announce those opportunities. You can always reach out to me. For the behavioral health teaching facility for mental health professional jobs, you can talk to Dr. Kimmel. All the other things that they're going to be hiring for, they'll be posted on UW Hires when they're ready. That's it. Sweet, short and sweet.
Short and sweet and very good. And thank you, Becky, and all of our staff for all amazing work you do to help all of us stay on track and move this important work forward. So Couple more comments. The one thing that Becky has done as we got this institute off the ground is build a really dynamite website. And if you want to stay, you can be on the listserv, but you can also come to our website and learn about any of the things we're doing. Who is in the institute? What are we focusing on? What are the actual projects that are going on? What training programs do we have? What funding opportunities are there? Who are we recruiting and how can we help with that? All of that stuff you can find on our website. And there's a little flyer, I think, at the front if you want to take that. We also sponsor year-round as part of our department a Grand Round series that is bringing really great speakers, local, but also national and international speakers. We had a great talk last year, for example, about the gut microbiome immune connection. We had talks about the geriatric mental health workforce, about the uses of electroconvulsive therapy. You're welcome. These are all open to the public. They're also archived. They're on our department website. You can go visit them, look at them anytime. And those talks are supported by the Institute. And then finally, as Becky said, we've talked at you most of the morning and you've been very patient and nice. And now we have some lunch for you. It's outside. We have a couple of really neat posters for those of you who would like to learn a little bit more about some of the ongoing projects. Some of the work is on posters that are, I think, when you get out to the left, right, all the way down, you'll see them. Take a look at them. And if you parked, get a parking voucher if you don't have it yet. The parking is on us. And come out, connect, talk, mingle, and let's all give, as I said earlier today, I think what we're going to see this morning is what can happen in a short time, 2 or 3 years, even in the midst of a pandemic, if you take 100 really smart people and you unleash them on a really difficult problem. And I think you got a good taste of that now. And so I want to thank all of you. You're all part of that. I want to give a huge thanks again to the Garvey family for making it possible. Anna Mari, I think, gave us some beautiful comments about how does this work fit with what the university is about. And I think it's a beautiful fit. And it really draws on all of the strength that we have as a big university. So thanks to all of you. Thanks for coming. I hope you have a great day. We'll be out here and feel free to join us. Thank you.